All right, starting with gynecology, 468 to 507. All right, so 468, menarche and normal female development. Telarche, breast development onset is 8 to 13 years of age. That leads to pubarche, that's pubic hair growth. That leads to growth acceleration. To menarche, onset is 10 to 16 years of age. Okay, ages of these stages of development vary by race and ethnicity. Key fact here, normal male development is later in onset with a different order. Testicular enlargement onset is 9 to 14 years of age. Penile growth, and that leads to pubarche, that goes to growth acceleration, and then the facial hair. Okay, normal menstrual cycle. The progression of a normal menstrual cycle is detailed here. Figure this shows the cyclic events in the ovary, follicular, and luteal phase, and the corresponding events in the uterus. Proliferative and secretory levels throughout a typical 28-day cycle. Okay, so let me make this a little smaller. Okay. So the phases of the ovarian uterine cycle. Okay. Phases of ovarian cycle: follicular phase, luteal phase. So first, what happens is hypothalamus releases GnRH. Okay. GnRH goes to anterior pituitary and stimulates the release of FSH and LH. Okay. So then during the follicular phase, the menses occur in follicular phase. It's about to end, right? So it's ending here. FSH and LH stimulates developing follicle, right? FSH is follicular stimulating hormone, so that's what that does. Okay, so follicle gets stimulated. When follicle gets stimulated, it produces estrogen, and estrogen in turn causes the, how do you call this, the ending of menses. Okay, that little spike right there. So then the follicle matures, becomes Graafian follicle. Okay, so as the follicle matures, that's when the estrogen level rises. Okay, um, and then it keeps going. This is called the proliferative phase, where the arteries get produced, I guess, and the spiral artery and all that. Okay. Then once the follicle is up, and then we have a spike in what produces this LH? I think it's when the follicle is really up. So I guess they'll explain that here. Okay. So then the estrogen is up, then we get the LH surge. Okay, so when we get the LH surge, the estrogen reduces. Why? Because during LH surge, the luteal phase starts, and what commences the start of the luteal phase? It's when the follicle ruptures, right, to release the ova. So when that happens, that's when the luteal phase starts, because now the Graafian follicle, it becomes corpus luteum to produce progesterone and estrogen in that case. Okay, so and this is when you have the progesterone, that's when the secretory phase happens in the luteal phase. Okay, and then once the corpus luteum itself becomes smaller, both the hormones levels decreases. When they decrease, we get menses. Okay, because there was no pregnancy there. So luteal phase is basically what we want for a proper implantation of the fertilized ovum. Okay, so after that, the corpus luteum becomes the corpus albicans, and that's that. Okay, so we have over here primordial follicles, endometrium, and that's it. So menstruation and follicular phase. Okay, so let me get this down here. So we can look at this while we do that. Okay. So menstruation. Okay, let's make this bigger now. Okay. Starts with menstruation and ends at luteinizing hormone surge, ovulation. Right, so right there. May vary, but typically lasts about 13 days. Okay. Increase in frequency of gonadotropin releasing hormone, pulse. Okay, leads to increase in follicle stimulating hormone. That gets the follicle growth. So growth of follicles happen there, and that causes increase in estrogen production. Okay, it results in the development of straight glands and thin secretion of the uterine lining. Okay, so this is the proliferative phase. Okay, so right there. Okay. Right, so results in development of straight glands and thin secretions of the uterine lining, proliferative phase. By late follicular phase, dominant follicle is selected and increase in size. Uterine endometrium has thickened, and cervical mucus is becoming copious, thin, and stretchy. Okay, so right there. So we want that for now. Okay. Now we're on ovulation. Ovulation, estradiol reaches a peak. Okay, so right there. That causes a positive feedback to the pituitary gland. Right, so that was the one. So we gotta send that up to the pituitary gland right here. And what does that do? So positive feedback to the pituitary gland. This causes the LH surge. So when you have that, that's what produces the LH surge. Smaller FSH rise in that as well. Okay, that rupture of the ovarian follicle and release of mature ovum, travels to oviduct and or uterus. Okay, ruptured follicular cells differentiate into corpus luteum. Okay, and then coming to, so that was on day 14. Now we're on to luteal phase, day 14 to 28. Okay. Length of time 10 to 14 days. That the corpus luteum can survive without further LH or human chorionic gonadotropin stimulation. Okay, so corpus luteum can survive without further LH or human chorionic gonadotropin stimulation. Change from estrogen to progesterone predominance. Okay, so now there will be more progesterone than estrogen here. Corpus luteum produces progesterone and some estradiol, allowing the endometrial lining to develop thick and tortuous endometrial glands with thick secretions. Okay, the secretions are there to catch the ovum, fertilized ovum. Okay, so secretory phase. In the absence of fertilization and implantation, if there is no implantation, then there is decrease in LH. Okay, so that's where the LH decreases. Okay, that causes decrease in progesterone and estradiol by the corpus luteum. This causes sludging of the endometrial lining. Okay, so that's when the menses occur. Okay, with decreased estrogen and progesterone, there is no longer negative feedback to FSH, which then increases and restarts the menstruation follicular phase. Okie dokie. So key fact here, LH surge triggers ovulation and initiates production of progesterone. Okay, so let's go back just to understand and memorize this. So we have FSH, LH coming in, that stimulates the follicle. Once the follicle is matured, it produces estrogen, okay, and a little bit of progesterone, but not to the amount of estrogen. Okay, so when we have peak level of estrogen, that's what causes a positive feedback loop to the anterior pituitary, and then the anterior pituitary causes the LH surge and a little bit of a rise in FSH as well. When the LH surge occurs, that's what causes the predominance of progesterone in the body instead of the estradiol, and that's when you get the tortuosity of um, the endometrial lining and secretory phase happening, and the luteal phase, and that's it. Okay. Uh, abnormalities of the menstrual cycle. Okay, so key fact here: if onset of secondary sexual characteristics is seen before 8 years of age, workup for precocious puberty by determining bone age and conducting a GnRH stimulation test to distinguish central form peripheral precocious puberty. Okay, what? If onset of secondary sexual characteristic is seen before 8 years, okay. Workup of precocious puberty by determining bone age and conducting a GnRH stimulation test to distinguish central from peripheral precocious puberty. Okay, so that's how we do that. Okay, so onset of secondary sexual characteristic in a child less than 8 years of age. Subtypes are as follows. See this table. Central precocious puberty, early activation of hypothalamic GnRH production, and then we have peripheral precocious puberty, that's results from GnRH independent mechanisms. Okay, so causes of precocious puberty development: central and peripheral. So what causes the central, which is the GnRH dependent? Constitutional idiopathic, hypothalamic lesions like hematomas, tumors, congenital malformations, dysgerminomas, hydrocephalus, central nervous system infections, CNS trauma, irritation, pineal tumors, rare, neurofibromatosis with CNS involvement, and tuberous sclerosis. Peripheral GnRH independent ones, the causes are congenital adrenal hyperplasia, adrenal tumors, McQueen-Albright syndrome, polyostotic fibrous dysplasia, okay, gonadal tumor, especially a granulosa cell tumor which secretes estrogen, okay, exposure to exogenous estrogen, ovarian cyst female, and hypothyroidism. Okay. Yeah, makes sense. Hypothyroidism can also cause precocious puberty. Okay. And everything else basically makes sense. A lot of it has to do with the adrenals, right? Because it's the second organ in the hypothalamic adrenal gonadal axis. Okay, and the first one is the hypothalamic pituitary. So that would be central. Okay. History and physical examination. Okay, wait. The key fact: a patient with McQueen-Albright syndrome presents with precocious puberty, cafe au lait spot, and bony abnormalities, polycystic fibrous dysplasia. Key fact: in central precocious puberty, you will have increased estradiol, LH, and FSH. In peripheral precocious puberty, you will have increase in estradiol, but decrease in LH and decrease in FSH. Okay, because the estradiol will throw back the loop, and then they will stop producing the LH and FSH. Whereas in central precocious puberty, um, they don't listen to the feedback, so they keep on producing all of these. Okay. History and physical examination. Risk factors: smoking, immunosuppression, human papillomavirus infection, signs of estrogen excess, breast development, and possibly vaginal bleeding, suggests ovarian cysts of tumors, signs of estrogen excess, pubic and or axillary hair, enlarged clitoris, and or acne, suggests adrenal tumors or congenital adrenal hyperplasia. Um, that's CAH, congenital adrenal hyperplasia. Okay. So signs of excess, estrogen excess, which is breast development and possibly vaginal bleeding, such as ovarian cyst or tumor. Signs of estrogen excess, okay, such as adrenal tumor as well. Okay. Along with pubic and axillary hair, enlarged clitoris, and acne. Okay. Smoking, immunosuppression, and HPV infection. Diagnosis. Workup of precocious puberty includes the following: bone age. Within 1 year of chronologic age, puberty either has not started or has just begun. More than 2 years ahead of chronologic age, puberty either started more than 1 year ago or recently started with rapid progression. GnRH agonist, which is leuprolide stimulation test, increased LH than central precocious puberty. CNS tumor may be detected on MRI versus constitutional precocious puberty. If there is no increase in LH, then peripheral precocious puberty. Okay. Ovarian cyst, adrenal or gonadal tumor may be detected on ovarian, gonadal, and or adrenal ultrasound versus exogenous estrogen or congenital adrenal hyperplasia. Okay, so if we do leuprolide stimulation test, if there is increased, it's central. If it doesn't increase in LH, then peripheral. Okay, quite simple. Treatment: central precocious puberty, leuprolide is first-line therapy. Physical changes regress or cease to progress. Peripheral precocious puberty, the physician should treat the cause. Okay, so in central, leuprolide is first-line therapy. Okay, physical changes regress or cease to progress. Okay. Peripheral precocious puberty, the physician should treat the cause, ovarian cyst. If that's the case, then no intervention is necessary, as cysts will usually regress spontaneously. Congenital adrenal hyperplasia, then treatment with glucocorticoids, right? Mhm. Oh, okay. Depending on the enzyme deficiency, mineralocorticoid and sodium chloride supplementation may be necessary. Adrenal or ovarian tumors, okay, these require surgical resection. McEwen-Albright syndrome, estrogen blockers such as tamoxifen or drugs that decrease estrogen synthesis such as aromatase inhibitors, for example, anastrozole, or other synthesis blockers. Ketoconazole or testosterone may be effective. Okay, so for adrenal and ovarian tumors, surgical. For McEwen-Albright, SERMs, right? That's what they're called. Estrogen blockers, such as tamoxifen, or drugs that decrease estrogen synthesis, such as aromatase inhibitors, for example, anastrozole, or other synthesis blockers. Okay, so like ketoconazole or testosterone may be effective. I got McEwen-Albright syndrome. I forgot what it was, so this is from step 1. Due to GS protein activating mutations, okay, presents with unilateral cafe spots with ragged edges, polyostotic fibrous dysplasia, that's bone is replaced by collagen and fibroblasts, and at least one endocrinopathy, For example, precocious puberty. Lethal if mutation occurs before fertilization, affecting all cells, but survivable in patients with mosaicism. Okay. Uh, Primary amenorrhea, delayed puberty. I went into a rabbit hole here to understand what the polycystic fibrous dysplasia was. Okay, so let me organize it here. So first one we gotta look at is that there could be monostotic or fibrous dysplasia. Okay, so the polyostotic one is the Albright syndrome, right? Fibrous dysplasia involving nearly all bones or skeleton, pigmented lesions of skin, and endocrine disturbance. But there can be also monostotic, that's Hefe syndrome, Hefe type, I guess, or Jaffe, I don't know. I'm gonna say Hefe. Fibrous dysplasia involving large number of bones, plus pigmented lesion of skin. Okay. So what do we see in these? Let me do this one first. Fibrous dysplasia, bones involved, and polyostotic, you have femur, tibia, pelvis, ribs, spine. Okay, so these are the most common uh, locations. Uh, you can get McEwen-Albright syndrome that's associated with extraskeletal manifestations like cafe-out spot, macules, precocious puberty, prolactinomas, and hyperthyroidism. Also, testicular enlargement, ovarian cyst, renal phosphate wasting, intraduct papillary, neoplasm in pancreas. And then another one is Mazabrod syndrome associated with intramuscular myomas. Okay, on the other side, we have monostotic, that's 80% of the patients. Okay, eponym, that's Hefe-Lichstein disease. There's Lichstein, and then that sounds like a Jewish name. It could be two different last names then. Okay. Most common, because it sounds Spanish. Most common locations are ribs, skull, femur. Okay. So then I was looking at what the Hefe one was. So what Hefe-Lichstein disease is, it's a very rare congenital genetic disorder characterized by bone lesions that can degenerate into sarcoma, associated with precocious puberty and other hormonal dysfunction is possible. It is either monostotic fibrous dysplasia or poly, with cafe spot without endocrine dysfunction. Okay, so these are now just the photos of polyostotic. Okay, this is Hefe one. Okay, and then all of these one. This was also Hefe. Okay, the ribs and arm and leg. Okay, here we have polyostotic one. Okay, so these and that. Okay, and that, the spine as well. There's monostotic. Okay, large number of bones. The fibrous dysplasia lesion can be monostotic or polyostotic. Okay, so right there. Okay, dysplasia right there. And this. All right. Primary amenorrhea, delayed puberty. Okay. Primary amenorrhea is the absence of menses by 15 years of age with secondary sexual development present. Delayed puberty is the absence of secondary sexual characteristics by 13 years of age. Okay, so if we have sexual characteristic development by 15 years of age, but no menses, then that's primary amenorrhea. And if we don't have menses and there is no sexual secondary characteristic by the age of 13 years of age, then that is delayed puberty. Okay. History and physical examination: absence of secondary sexual characteristics, no estrogen production. Okay. So absence of secondary sexual characteristics. So we're talking about delayed, right? Primary ovarian insufficiency. Okay, most common cause, approximately 50%. Depletion of ovarian follicles and oocytes, most commonly from Turner syndrome, 45XO. The physician should consider a history of radiation therapy and chemotherapy or gonadal dysgenesis. Okay. Central hypergonadism, okay, uh, can be caused by a variety of factors, including the following. Okay, uh, undernourishment, stress, hyperprolactinemia, or exercise. Okay. Okay, so undernourishment, stress, hyperprolactinemia, or exercise. Okay, so can be a variety of factors. Central hypogonadism. Okay. Central nervous system tumor. Consider prolactin secreting pituitary adenoma if galactorrhea or cranial irradiation. Kalman syndrome. Okay, it's associated with anosmia. It's isolated gonadotropin deficiency and constitutional growth delay. Presence of secondary sexual characteristics, estrogen production, but other anatomic or genetic problems. Etiologies include the following. Okay, so we have secondary sexual characteristics, estrogen production, but other anatomic or genetic problems. Okay, so there's Mullerian agenesis, that's XX chromosome genotype. Okay, so XX genotype with normal female testosterone levels, absence of upper two-thirds of the vagina, uterine abnormalities. Okay, so we have uterine abnormalities in that. Okay. Imperforate hymen that presents with hematocolpus, that's blood in vagina, that cannot escape, along with the bulging hymen. Complete androgen insensitivity. Okay. Complete androgen insensitivity. XY genotype with elevated testosterone levels. Presents with breast development, aromatization of testosterone to estrogen, but amenorrhea and lack of pubic hair. Okay. So complete androgen insensitivity. So we have XY genotype with elevated testosterone level, presents with breast development, aromatization of testosterone to estrogen, but amenorrhea and lack of pubic hair. Okay. And we have uh, adrenal hyperplasia. Okay. Can present as virilization with amenorrhea or oligomenorrhea. Okay. Often presents in infancy with ambiguous genitalia. Physical examination, pubertal development, genital exam, signs of androgen excess, physical features of Turner syndrome, uh, diagnosis, perform pregnancy test, assess for anatomic abnormalities. Okay. Let me read the key fact here first. For Turner syndrome, think streak gonads, shield chest, amenorrhea, web neck, aortic coarctation, and bicuspid aortic valve. Okay. Key fact: the first step in the workup of primary or secondary amenorrhea is pregnancy test. The first step is the workup of primary or secondary amenorrhea his pregnancy test. Cool, cool, cool. Okay, diagnosis. Perform pregnancy test. Okay. Assess for anatomic abnormalities, for example, imperforate hymen, physical examination, ultrasonography. Uh, Uterus absent. Obtain karyotype and serum testosterone levels to assess if patient has abnormal Mullerian development. Okay, so 46XX, normal female testosterone levels, or androgen insensitivity 46XY, normal male testosterone levels. Okay, so we do karyotype to find out what the chromosomes are, and then also the testosterone level to figure out what the levels for that are, and to assess if patient has abnormal Mullerian development, that would be this, but normal testosterone level and 46XX, or androgen insensitivity, which is 46XY, with normal male testosterone level. Okay, in both cases, testosterone level is normal. Okay, but they both don't have uterus, and that's why we want to figure out which one it is. If there's uterus present, then check FSH, LH levels. If FSH is increased, primary ovarian insufficiency. Obtain karyotype for Turner syndrome 45XO. Normal or decreased FSH, central hypogonadism, constitutional growth delay. Measure serum prolactin and thyrotropin, especially if galactorrhea is present. Okay, so normal reduced FSH, then central hypogonadism, constitutional growth delay, measure serum prolactin and thyrotropin, especially if galactorrhea is present. If signs of hyperandrogenism, okay, then consider androgen secreting neoplasm or congenital adrenal hyperplasia. Check serum testosterone, DHEAS. Okay, so you would check that for that. If hypertensive, then evaluate again for congenital adrenal hyperplasia for 17 hydrolase and 11 hydroxylase deficiencies. Okay, in either way, you would either have a increased weak mineralocorticoids or increased mineralocorticoids. Okay, so that would cause hypertension. See table this for etiologies and this figure for workup of primary amenorrhea. Treatment. If it's constitutional growth delay, no treatment is necessary. Hypogonadism, then begin hormone replacement therapy with estrogen alone at the lowest dose. Begin cyclic estrogen progesterone therapy 12 to 18 months later if the uterus is present. Anatomic. Requires surgical intervention. Okay. Okay, a lot of charts there. Let's go through it. Etiologies of primary amenorrhea. So if we have constitutional growth delay, then GnRH is going to be decreased. In turn, there won't be any stimulation for LH-FSH, so that's going to be reduced. Since we don't have LH-FSH, the follicles are not going to be stimulated, so we have reduced estrogen and progesterone levels, pre-puberty levels. Okay. Etiology. Start of puberty began behind schedule. Okay. Hypogonadotropic hypogonadism. Okay, so that's also central. Okay, so GnRH is going to be reduced. Again, same thing. LH, FSH is going to be reduced or normal. Okay, because it could be reduced, but not below. It could be below the normal levels. That's why. Okay. And since this is reduced estrogen progesterone, again, follicles not going to be stimulated, so it's going to be reduced. Etiology. Hypothalamic or pituitary problem, low caloric intake, excessive exercise. Okay. Then we have hypergonadotropic hypogonadism. So hypogonadotropic means it's not central anymore because it's releasing GnRH. However, the gonads are not, responding to it. Okay, so hypothalamus is releasing GnRH, anterior pituitary is releasing LH, FSH, but the gonads are not responding to those signals. So it's going to be reduced estrogen, progesterone. So ovaries have failed to produce estrogen in that case. Okay, anovulatory problem. Okay, so ovulation is not happening. So GnRH could be increased or decreased in that case. LH, FSH is going to be normal. Estrogen is going to be increased and or decrease in progesterone. Okay, so etiology is that there's a problem with estrogen receptors, immature hypothalamic pituitary ovarian axis, adolescents only. And then anatomic problem, in which case GnRH is normal, LH, FSH is normal, estrogen, progesterone is normal. Etiology is menstrual blood unable to get out. Okay. So history and physical examination completed. What is this? So workup of primary amenorrhea. Okay, cool. So if we do it, history and physical examination completed for a patient with primary amenorrhea. So presence of secondary sexual characteristics. Okay, so if there is, then we go to ask, is uterus present? If there isn't any uterus, we know to do the karyotypic analysis, right? So we're gonna do that, and if we get 46XY or 46XX, and then we do the testosterone level as well after that, right? To figure out if it's androgen insensitivity syndrome or Mullerian agenesis. Okay. If uterus is present, then there is outflow obstruction, yes or no. If there is yes, then that's imperforate hymen or transverse vaginal septum. If there is no outflow obstruction, then evaluate as for secondary amenorrhea. Okay. If there is no secondary sexual characteristics developed, then what we do is we measure FSH and LH. If there's high FSH and LH, that means it's not central anymore. If it is low FSH and LH, then it is central and it is hypogonadotropic, and that's why we have hypogonadism. But if it is high FSH and LH, then it is peripheral now, right? Because central is working fine, it's releasing FSH and LH. Okay, so we have hypergonadotropic, but now we have hypogonadism. So we got to figure out what's happening there. So again, we will do karyotype analysis. Okay, usually it could be Turner, they said, that causes this because of streak ovaries. So Turner 45XO. It could be 46XX, in which case they have premature ovarian failure, and it could be 46XY, and this is called the Swyer syndrome. Okay, I'm going to look into that. Hold on. So I looked into what Swyer syndrome is. So they basically look like they have a rare genetic condition in which people have a X chromosome and a Y chromosome, the usual pattern for males, look female. They have normal female reproductive organs, including a uterus, fallopian tube, and vagina. Okay, so they look like female appearance, right? However, they have a X and Y chromosome for that. Okay, so that's what Swyer syndrome is. Okay. Progestin challenge. Okay, so workup of secondary amenorrhea. So that's for this. Let's come back to this after we read what this is. Okay. I'll put this down. So I don't forget to cover it. Did I miss any key facts? No. Right, so first step in workup of primary or secondary is pregnancy test. Okay. Secondary amenorrhea. The absence of menses for 6 consecutive months in females who have passed menarche. Etiologies include pregnancy, ovary, polycystic ovarian syndrome, premature ovarian insufficiency, chemotherapy, radiation. hypothalamus, neoplasm, functional hypothalamic amenorrhea, poor nutrition, exercise and stress, systemic illness, type 1 diabetes mellitus, celiac disease, pituitary gland, adenoma, for example, prolactin secreting, cellular masses, Sheehan syndrome, thyroid gland, hypothyroidism and hyperthyroidism, and uterus, Asherman syndrome, and cervical stenosis. Okay, so diagnosis, history and physical examination, that's first, and then exclusion of pregnancy with a pregnancy test, that's number 2 or number 1 in this, as we read before. If negative pregnancy, then measurement of FSH, thyroid stimulating hormone, and prolactin. Okay, so that's what we'll do. FSH, TSH, and prolactin. Okay. Okay. So increase in FSH indicates primary ovarian insufficiency. That means the central is fine, so it's something peripheral. So primary ovarian insufficiency. Increase in TSH indicates hypothyroidism. Okay. Again, if there's TSH, then hypothyroidism can cause that, right? Secondary amenorrhea. Increase in prolactin inhibits the release of GnRH, and thus LH and FSH, points to pituitary pathology, and MRI of the pituitary gland should be ordered to look for prolactin secreting pituitary adenoma. Okay. Then initiation of progestin challenge. 10 days of progestin. See this figure right here, for an algorithm of the diagnostic workup. Okay, so let's look at that. So progestin challenge. We give progestin, okay, and withdrawal bleed. Okay, then PCOS suggested by LH-FSH ratio of more than 2, or idiopathic anovulation. We give progestin and there's no withdrawal bleed. Then we check for the FSH level. If there is increase in FSH, then hypergonadotropic hypogonadism, premature menopause, primary ovarian insufficiency. If there is reduced FSH, then cyclic estrogen progesterone test we do, and then if there's withdrawal bleed, in that case, then it will be hypogonadotropic hypogonadism. And if there's no withdrawal bleed, then endometrial or anatomic problem. Okay. So I looked it up. It's Mittelschmerz or Mittelschmerz if you're German. Okay. Moving on to abnormal uterine bleeding. Okay, key fact here: postmenopausal vaginal bleeding is cancer until proven otherwise. Okay. So abnormal uterine bleeding. Normal menstrual bleeding ranges from 2 to 7 days. Abnormal uterine bleeding refers to alterations in quantity, duration, or frequency, classified by the acronym PALM-COIN. PALM refers to structural causes, that's polyps, adenomyosis, leiomyomas, and malignancy or hyperplasia. And COIN refers to non-structural causes, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. History and physical examination. Assess the extent of bleeding, oligoamenorrhea, an increased length of time between menses, 35 to 90 days between cycle. Polymenorrhea, frequent menstruation, less than 21-day cycle. Heavy menstrual bleeding, previously termed menorrhagia. Okay, so we don't call it menorrhagia anymore, we call it heavy menstrual bleeding. Increased amount of flow, more than 80 ml of blood loss per cycle, or prolonged bleeding, flow lasting more than 8 days. Heavy menstrual bleeding may lead to anemia. Intermenstrual bleeding, previously termed metrorrhagia, Metrorrhagia. Okay. Intermenstrual bleeding. Okay. Bleeding between periods. And then we have heavy prolonged menstrual bleeding, previously termed menometrorrhagia. Okay. Excessive and irregular bleeding. Okay. So all of these are now termed abnormal uterine bleeding. So it's under the umbrella of that. Okay. On pelvic examination, the physician should evaluate the uterus and the cervix for a potential etiology of the bleeding. An enlarged uterus may be suggestive of pregnancy or uterine myomas. A cervical mass or other cervical abnormalities are concerning for cervical malignancy, infection, or an endocervical or prolapse endometrial polyp. Diagnosis: beta HCG test to rule out pregnancy, CBC to evaluate for anemia, pap smear to rule out for cervical cancer, gonorrhea, chlamydia probe to rule out cervical bleeding from cervicitis, thyroid function test, and prolactin to rule out hypothyroidism, hypothyroidism, and hyperprolactinemia. Platelet count, prothrombin time, partial thromboplastin time to rule out von Willebrand disease and factor 11 deficiency, primarily in adolescent patients. Okay, ultrasonography to look for uterine masses and polycystic ovaries and to assess thickness of the endometrium. Indications for an endometrial biopsy: if the endometrium is more than 4 mm or more in a postmenopausal women, or if the patient is more than 45 years of age, okay, we will do endometrial biopsy. If the patient is more than 35 years of age with risk factors for endometrial hyperplasia, for example, obesity and diabetes, in that case, we'll do endometrial biopsy as well. See this figure for guidance on which premenopausal patient should have an endometrial biopsy as part of their workup for abnormal uterine bleeding, and see this figure for guidance on management of endometrial biopsy results. Treatment. Okay. Acute heavy bleeding. High dose estrogen intravenously stabilizes the endometrial lining and typically stops bleeding within 1 hour. Okay, so high dose estrogen intravenously and stabilizes the endometrial lining and typically stops bleeding within 1 hour. When bleeding stabilizes, the physician can transition patient to combined oral contraceptive or add progestin. If estrogen is contraindicated, the physician can give high dose progestin therapy alone. If bleeding is not controlled within 12 to 24 hours, dilation and curage may be indicated. Okay, so we give estrogen. If estrogen is contraindicated, we give progestin, high dose. If bleeding is still not controlled within 12 to 24 hours, then we do DNC. Okay. Key fact here: for acute life-threatening AUB, IV estrogen best for adolescent and younger patients. Consider surgical management, DNC, as first line treatment for patients more than 45 years of age and whom through thorough endometrial sampling is indicated, and or in whom the cardiovascular risk for systemic IV estrogen is high. And the key fact: combined hormonal contraception and the progestin containing IUD are highly effective treatment options for non-life-threatening menorrhagia. Okay, ovulatory bleeding, excessive bleeding associated with normal menstrual cycles. Okay, NSAIDs less than blood loss. NSAIDs reduce blood loss. Tranexamic acid can be given for 5 days during menses. If the patient is hemodynamically stable, the physician can prescribe oral contraceptive pills, oral or injectable progestin, or insertion of progestin IUD. Anovulatory bleeding. Goal here is convert proliferative endometrium to secretory endometrium to reduce the risk for endometrial hyperplasia and cancer. Progestin for 10 days to stimulate withdrawal bleeding. Combined hormonal contraception and progestin IUD. Okay, so we have ovulatory bleeding, excess bleeding associated with normal menstrual cycle. Then NSAIDs to reduce blood loss. Tranexamic acid can be given for 5 days during menses. If the patient is hemodynamically stable, physician can prescribe oral contraceptives and injectable progestin and insertion of IUD. In anovulatory bleeding, we do convert proliferated to secretory endometrium, so progestin for 10 days to stimulate withdrawal bleeding. Combined hormonal contraception and progestin IUD. Okay. First off, acute heavy bleeding. Okay, we went through that already in detail. Okay. If medical management fails, then DNC, hysteroscopy to identify endometrial polyps or to perform direct uterine biopsies. Okay. So we have abnormal uterine bleeding, history and physical examination, and pregnancy test, TSH, and prolactin levels. If they're abnormal, manage other causes of AUB. Rule out other causes, okay? Systemic disease, medication effects, cervical pathology, infection, okay? Concerns for endometrial pathology, okay? If it's more than 35-year-old, suspected in ovulation, then endometrial biopsy. If it's less than 35-year-old, risk for endometrial cancer, again, we'll do endometrial biopsy there as well. If it's less than 35 years of age, but they don't have any risk of endometrial cancer, then trial of combination oral contraceptives, cyclic progestin, or medroxyprogesterone acetate. Okay, and if there's continued irregular bleeding, then we'll do endometrial biopsy there as well. Okay, risk factors for endometrial cancer are chronic anovulatory cycles, obesity and nulliparity, diabetes mellitus, and tamoxifen therapy. Okay, endometrial biopsy. Okay, so this is management of endometrial biopsy results. If you have normal endometrium, then combination oral contraceptive pills, cyclic progestin, or medroxyprogesterone acetate, okay, and bleeding resolves. Or another outcome is bleeding continues, in which case you'll do transvaginal ultrasound and surgical therapy, ablation, myomectomy, and hysterectomy. In endometrial biopsy, you get hyperplasia without atypia, then medroxyprogesterone acetate, megestrol, or levogestrel IUD. Repeat endometrial biopsy in 3 to 6 months. If continued irregular bleeding, then you'll refer to gynecologic oncologists. Okay. If you did endometrial biopsy and you get hyperplasia with atypia, then of course refer to gynecologic oncologist. And if you have endometrial cancer, then same thing, gynecologic oncologist. Okay, continuing with, if medical management fails, then DNC, hysteroscopy to identify endometrial polyps or to perform direct uterine biopsies. Uterine artery embolization, hysterectomy, and endometrial ablation appropriate for females for whom hormonal treatment fails, who no longer desire fertility, who have symptomatic anemia and or who experience a disruption in their quality of life from persistent unscheduled bleeding. Key fact: complications of AUB include anemia. Presence of AUB raises concern for underlying endometrial hyperplasia and or carcinoma. Another key fact: multiple sexual partners and nulliparity are not Absolute contraindications to IUD use. Key fact: combined hormonal methods of contraception decrease the risk for endometrial and ovarian cancers. Okay. Complications of AUB include anemia, presence of AUB, okay. All right, on to contraception. Contraception. 85% of actively sexually active women with no contraception will become pregnant within 1 year. 85%. That's quite a statement. This table describes the effectiveness of contraception method along with their relative advantages and disadvantages. See this table for contraindications to common methods of contraception. Emergency contraception methods prevent pregnancy after unprotected sex and contraceptive failures. This table describes the various methods of elective contraception. Sorry, emergency contraception. Easy. They just literally told me right there. Okay. Contraception methods, method, mechanism, advantages, and disadvantages. Most effective, more than 99%. Okay, most common, okay. So, and these are very effective ones. And then we have moderately effective ones and less effective ones. Okay, so let's start with the most effective ones, 99% of the time. So, copper intrauterine device. Let me just do this. Okay, so IUD, copper intrauterine device. Foreign body results in inflammation. Copper has a spermicidal effect. Advantages: effective for up to 10 years, immediate fertility once removed, no hormonal exposure, safe with breastfeeding. Disadvantages is it increases cramping and heavier bleeding, 5% to 10%. Risk for uterine perforation, about 1 in 100, and increased risk for ectopic pregnancy, which is rare. Implants. This is progestin only implant. Mechanism is it inhibits ovulation. It increases cervical mucus viscosity. Okay. Effective for up to 3 years, immediate fertility once removed, safe with breastfeeding and lighter periods. Disadvantages is um, irregular periods, scarring at site of insertion, upper arm. IUD with progestin. So both of those together. Progestin leads to cervical mucus thickening and endometrial decidualization. Advantage of this is it's effective for 3 to 8 years depending on type of P4 IUD. Immediate fertility once removed, safe with breastfeeding, lighter periods, less cramping. Disadvantages are spotting up to 6 months, acne, risk for uterine perforation, 1 in 100, increased risk for ectopic pregnancy, which is rare. Surgical sterilization, vasectomy, tubal ligation. Okay, so there's no mechanism for that. Advantages are permanently effective and safe with breastfeeding. Disadvantages are tubal ligation, irreversible, increased risk for ectopic pregnancy, which is rare. Vasectomy, most failures result from non-waiting for 2 negative semen samples. Okay. Don't get zoned out. Okay. Now we're doing very effective ones, 90% to 99% time effective. OCPs, combination estrogen and progestin. Okay, a mechanism here is it inhibits FSH, LH, suppressing ovulation, thicken cervical mucus, decidualization, endometrium. Advantages are decreased risk for ovarian and endometrial cancers. Predictable, lighter, less painful menses, can improve acne. Okay. Disadvantage. So the advantage of reduced risk for ovarian and endometrial cancer is pretty cool. So there's a A there. I'm going to read what that is. Other combined hormonal methods, for example, patch, ring, may also protect against endometrial and ovarian cancers. However, data are still lacking, given their relatively recent introduction. Okay. So disadvantages, requires daily compliance, breakthrough bleeding, 10% to 30%, thromboembolism risk, especially in smokers more than 35 years of age. Cannot be used in patients of any age who have migraines with aura. Hypertension, gastroesophageal reflux disease, progesterone relaxes the lower esophageal sphincter. Okay, so again, requires daily compliance, breakthrough bleeding, 10% to 30%, thromboembolism risk, especially in smokers more than 35 years of age, cannot be used in patients of any age who have migraines with aura. Okay, so that gotta remember that one. It cannot be used in patients of any age who have migraines with aura. Hypertension, uh, GERD. Okay, why? Because progesterone relaxes the lower esophageal sphincter. We read about that already. Okay. Transdermal patch, the patch. Okay. Same as OCPs. Predictable, lighter, less painful menses, weekly administration, thromboembolism risk, especially in smokers more than 35 years of age, patients with chronic hypertension as well. Okay. Thromboembolism risk for this, especially in smokers. Okay. With hypertension. Vaginal ring, same as OCPs, can make periods more regular, can be placed intravaginally for 3 weeks, removed for 1 week. Menses will occur during this time. Okay, so advantages is that it can make periods more regular and it can be placed intravaginally for 3 weeks, removed for 1 week. Okay. Disadvantages may increase vaginal discharge, spotting first 1 to 2 months, thromboembolism risk, especially in smokers more than 35 years of age, patients with chronic hypertension. So I notice in very effective methods, all of them have thromboembolism risk. Okay, most of them. So here where it differs. Medroxyprogesterone. Okay, so mechanism here is intramuscular injection of progestin. Uh, Suppresses ovulation and decellulization of decel decidualizes the endometrium. Advantages are lighter or no periods, and each shot works for 3 months. Disadvantages: irregular bleeding, weight gain, decreases in bone mineral density, okay, and delayed fertility after discontinuation up to 10 months. Progestin only mini pills. Uh, Thickened cervical mucus. Advantages are safe with breastfeeding, and disadvantages are require strict compliance with daily timing. Okay, so from this, what I got is OCPs are the standards, right? It's more convenient for people. As soon as they stop taking it, they go back to being fertile right away. Whereas transdermal, it requires weekly administration for the patch. With the ring, it requires you can do it for 3 weeks, and then it requires removal for 1 week at least. Okay, and that's when the menses will occur. Okay, uh, with medroxyprogesterone, each shot occurs 3 months, lasts for 3 months, and then if you want to discontinue, to for family planning or whatever, it takes up to 10 months. So you gotta keep that in mind that if you want to get pregnant, then you gotta stop taking it 10 months ahead of your planning. And in progestin only, it's safe with the mini pills. It's safe with breastfeeding, but it requires strict compliance with daily timing. Okay, You can't be off at that. Okay, now moderately effective 75% to 90% male condoms. It is a latex sheath covering the penis. The only method that effectively protects against pregnancy and STDs, including HIV. Disadvantages: possible allergy to latex or spermaticides. Diaphragms with spermicides, right? Mechanism: barrier inserted over the cervix to prevent entry of the sperm. Okay. Advantages: it's some protection against STDs as well. And disadvantages is must be fitted by the provider. Okay. And so I guess it must be removed by a provider too. Okay. Female condom, a barrier sheath that is inserted into the vagina. Some protection against STDs. Can be difficult to use. Fertility awareness methods, natural family planning. Sexual intercourse is avoided on days during the menstrual cycle on which conception is likely. So near the time of ovulation. Okay. Advantages: no adverse effects. Disadvantages are not reliable for patients with irregular menses, requires close monitoring of ovulation indicators, cervical mucus, basal body temperature, cell length. No STDs, HIV protection. Okay. Less effective, 68% to 74%. Okay. These are withdrawal, removal of the penis during ejaculation. Pull out game strong, bro. Advantages: no adverse effects. Disadvantages: no STDs, HIV protection. Not recommended as a primary method. Spermicide, a substance that inhibits sperm motility. Okay. Advantages: may be used as a secondary method. Disadvantages: not recommended as a primary method. Okay. All right. So contraindications to common methods of contraception: estrogen containing hormonal methods. Okay. So for that, what is A? Including includes OCP, vaginal ring, and transdermal patches. Okay. Now pregnancy, breastfeeding are contraindication. History of stroke, hypertension, deep venous thrombosis, pulmonary embolism, unexplained vaginal uterine bleeding, estrogen dependent, for example, breast cancer, benign or malignant liver neoplasm, abnormal liver function, current tobacco use, and more than 35 years of age, migraine with visual aura, diabetic retinopathy, or neuropathy. Okay, so all of these are contraindicated for OCPs, vaginal ring, and transdermal patches. Okay. IUDs. Progesterone and copper. What are the contraindications there? Severe uterine structural abnormality, bicornuate septate, known or suspected pregnancy, active gynecologic infection within 3 months, unexplained vaginal uterine bleeding, suspected gynecologic malignancy, copper IUD alone, copper intolerance, allergy, Wilson's disease, severe dysmenorrhea and or menorrhagia, progestin IUD alone, levonorgestrel allergy, breast cancer, acute liver disease, or liver tumor. Okay, so all of that for progestin. So progestin, we know about the estrogen contraindications. For progestin, it's levonorgestrel allergy, breast cancer, and acute liver disease or liver tumor. Okay. Emergency contraceptive methods. Method and mechanism. Advantages and disadvantages. Okay. Ulipristal, Selective progesterone receptor antagonist delays ovulation, can be used up to 120 hours after intercourse. Advantages: does not disrupt embryo post-implantation, safe for all patients, very effective, can be used in active pelvic infection, can be used longer after intercourse, more effective due to two mechanisms of action, preferred in patients with higher BMI. Disadvantages: expensive, requires a prescription. Okay. Uh, Levonorgestrel. This is a progestin only pill that delays ovulation, must be used within 72 hours of intercourse. Advantages: fewer nausea, vomiting, adverse effects than an oral contraceptive taper. Available without a prescription, and disadvantages are less effective than other methods, shorter window after intercourse for efficacy. Oral contraceptive taper delays ovulation, most effective within 72 hours of intercourse, but can be used up to 120 hours after intercourse. Okay, delays ovulation, most effective within 72 hours, but can be used up to 120 hours. So that's similar to, okay. Useful for patients who have OCPs at home, and disadvantages are nausea, vomiting, fatigue, headache, dizziness, breast tenderness, requires a prescription. Copper IUD. Copper particles disrupt sperm and ovum function, preventing fusion, may prevent implantation, can be used up to 7 days after intercourse. Advantages: the most effective emergency contraceptive method, 99% effective, can be used as emergency contraceptive and continued for up to 10 years of contraception. Disadvantage here are high initial cost of insertion. Okay, must be inserted by the provider, should test for pregnancy and STIs before insertion, cannot be placed during active infection. So disadvantages here are none of these methods provide protection from a treatment for HIV or other sexually transmitted infections. Okay. Reproductive endocrinology. Okay. Key fact here: in congenital adrenal hyperplasia, if the first number in the name of the deficiency enzyme is a 1, it is associated with hypertension. If the second number is a1, it is associated with hyperandrogenism, right? So if it's 11, it's going to be hypertension and hyperandrogenism. If it's 17, then hypertension because of weak mineralocorticoids, uh, and if it was, what was the other one? 21 and 17, right? So 17 hypertension and 21 would be hyperandrogenism because yeah, you will have increased amount of the DHEAs. So congenital adrenal hyperplasia. Congenital adrenal hyperplasia is a deficiency of at least one enzyme required for the biochemical synthesis of cortisol from cholesterol. Includes the following: 21 hydroxylase deficiency accounts for approximately 90% of CAH cases. Classic form is most severe and presents as a newborn female with ambiguous genitalia and adrenal insufficiency. Okay, so 21 is, okay, we'll cover that. With or without life-threatening salt wasting. Non-classic is a late onset form that presents with androgen excess on it, could be asymptomatic, cannot convert 17-hydroxyprogesterone. Oh, give me a sec. 1-hydroxylase deficiency. Where was I? I'll just start again. Account for approximately 90% of CAH cases. Classic form is most severe and presents as a newborn female with ambiguous genitalia and adrenal insufficiency, with or without life-threatening salt wasting. Non-classic is a late-onset form that presents with androgen excess, or it could be asymptomatic. Cannot convert 17-hydroxyprogesterone to 11-deoxycortisol. Okay, so you have decreased cortisol synthesis, increased adrenal stimulation, and increased ACTH and androgen. So and 11B beta hydroxylase deficiency, second most common cause of adrenal hyperplasia, cannot convert 11-deoxycortisol to cortisol or 11-deoxycorticosterone to corticosterone, also leading to increase in ACTH and androgen. History and physical examination. Okay, androgen excess, genital ambiguity, premature puberty, menstrual irregularity, infertility, hirsutism, acne, and rarely a palpable abdominal mass. Okay. So here we have cholesterol via STAR. What's that? STAR is steroidogenic acute regulatory protein, rate limiting step in steroid synthesis. Okay. So whatever that is, gets converted to pregnenolone via desmolase, cholesterol desmolase, right? And then already seen this in the first aid from step 1, and we also covered it in endo. So pregnenolone, progesterone, 11-deoxycorticosterone, which is a weak mineral corticoid. So in case we don't have aldosterone, but we have 11-deoxycorticosterone in high amounts, it will act similar to aldosterone. Okay, and that happens in 11-beta hydroxylase deficiency. 1 is in the front, so you will get hypertension because of that. Okay, and the 1 at the end is because you have now an excess of pregnenolone converting to 17-hydroxypregnenolone, and that gets converted to DHEAs, right? And then DHEAs goes on to doing its thing. So you'll get that. With 21-hydroxylase, since it doesn't have 1 in the front, it doesn't increase, it doesn't cause hypertension, and that's because we don't have the access to either the mineralocorticoid aldosterone or the weak mineralocorticoid, which is 11-deoxycorticosterone, right? Because it doesn't get converted there. So this will get passed on to this, and again, we don't have cortisol either, so we don't have glucocorticoids along with the mineralocorticoids, but it will get passed on again to androstenedione and DHEAs, so it will go on to doing its that thing there, but aromatase and here, right? So peripheral tissues, estrogen and DHT, Q, and the other thing here was that ACTH does the feedback loop and stimulates the formation of cortisol and androgens, but for aldosterone it gets stimulated by angiotensin 2. Okay, so even if you have a central problem with the ACTH and all that stuff, you're not going to have a problem with the ROS system because that is independent of that. Okay, so here we have a capsule. That's this outer layer is zona glomerulosa, GFR, right? So glomerulosa, then fasciculata, and then reticularis in the inner. Right? The deeper it gets, the sweeter it gets. So something like that. And then medulla for the catecholamines. Okay. Glucocorticoid synthesis pathway. Cool. Key fact: 21-hydroxylase deficiency can present with hypotension, whereas 11-beta hydroxylase and 17-hydroxylase deficiencies can present with hypertension caused by accumulation of deoxycorticosterone, right? The mineralocorticoid that we already talked about. Okay. Sorry. Diagnosis, physical examination, 21 hydroxylase deficiency. So you just have to remember where these ones are. So here it's 17 alpha hydroxylase. Here we have 21 hydroxylase and 17 beta hydroxylase over here. So it goes like that. 17, 21, 11. Cool. So 17 hydroxylase deficiency increases 17 OH progesterone levels, a substrate for 21 hydroxylase. This is part of newborn screen. A Cosentropin ACTH simulation test, gold standard, but not necessary if there is an increase in 17 OH. 11 beta hydroxylase deficiency, increase in serum 11 deoxycortisol and 11 deoxycorticosterone. Okay, both. Next, assessment of the following levels. Cortisol leads to decreased. Androstenedione, that is elevated in 21 hydroxylase and 11 beta hydroxylase. Deficiency, right arrow elevated. Also considered adrenal ovarian neoplasm. Dehydroepidiasterone, DHEA, elevated in 21 hydroxylase and 11 beta hydroxylase deficiency elevated. Also considered adrenal neoplasm and Cushing syndrome. Okay, and okay, so elevated in 21 hydroxylase, 11 hydroxylase deficiency. Considered adrenal neoplasm and also considered neoplasm, okay, and Cushing's. So cortisol. Okay. If salt wasting, then will also have decrease in aldosterone, in sodium, increase in potassium, and increase in renin associated with hypovolemia. Okay, so overview of congenital adrenal hyperplasia. Enzyme deficiencies, melanocorticoid, cortisol, sex hormone, blood pressure, labs, and presentation. Okay, so let me grab this to go with that. We don't need all that. Just need the first two. Alright. Let's place this over these. Okay. So 17 hydroxylase deficiency, right? So that, what will we have in melanocorticoids? It's going to increase, right? Cortisol, it's going to decrease. Okay. Sex hormones, it's going to be decreased, right? It's not getting converted because we don't have these converting enzymes. And then blood pressure, it's going to increase, right? Because of the aldosterone. Aldosterone causes reabsorption of sodium, and yeah, so that, and it excretes potassium, so K is going to decrease. Let's see if we have those right. Increase, decrease, decrease, increase in blood pressure, decrease in potassium. Okay. Labs, there will be decrease in androstenedione. Okay, so that one right there is going to be decreased. Okay. What's the presentation? If we have, we don't have the androgens. If it's a boy, then it's going to have ambiguous genitalia and undescended testes. Okay, but if it's a girl, then it will lack, they'll lack secondary sexual development. Okay. 21 hydroxylase. Sorry. What's gonna happen there? Okay. So here, it doesn't get converted to deoxycorticosterone or aldosterone or cortisol, right? So melanocorticoid reduced, cortisol reduced, sex hormone increased because now everything is getting converted to androstenedione. Okay. Blood pressure reduced, potassium normal, I guess, because it doesn't get affected, so it will stay normal. And labs, increases in androstenedione, I guess. Okay, and presentation, if it's a boy, cool. If it's a girl, then there's gonna be virilization. Uh, right, hirsutism, increased, all of that stuff. Okay, let's see. Um, so reduced, we said yes. Reducing cortisol, yes. Sex hormone, we said increase. Blood pressure is going to be decreased, and potassium is going to, I said normal, but it is increased in this case. Okay. So we'll have labs. It's increase in renin activity and increase in 17 hydroxyprogesterone. Okay. And most common is this one, and presents in infancy, salt wasting, or childhood, precocious puberty, and in uh, XX, it's going to be virilization. 11 beta hydroxylase. Okay, so that's first one. We have the weak mineralocorticoid. We already talked about that. So mineralocorticoids, it's going to be increased. Uh, it's going to be decreased, but I don't know which way the arrows would go. I guess we'll see. Decrease mineralocorticoids, but increase in weak mineralocorticoids. So I don't know how to place that, but anyways, cortisol is going to be decreased. Sex hormone, it's going to be um, increased, and blood pressure is going to be increased. So if blood pressure is increased, I guess we can say mineralocorticoids increased too. And potassium is going to be reduced. Labs, not sure about that. And presentation, it's going to be, since we have increase in sex hormones, again, virilization for XX. Okay, let's see. So, okay, so decrease in aldosterone, but increase in 11-deoxycorticosterone results in increase in blood pressure. Okay, so they give both. I already said that, so I'll give myself a point for that. Cortisol, well, said it decreases. Sex hormone, we said it increases. Blood pressure increase, yes, and potassium decrease, yes. Labs, so we go with renin activity on that one. It's going to be reduced because we have enough volume. And XX is virilization. Okay, hopefully that's clear. Okay, we have aromatase to convert estradiol to testosterone. Okay, and 5-alpha reductase gets inhibited by finasteride. Cortisol to cortisone gets inhibited by glycyrrhetinic acid. Okay, and that's it. All right. So all congenital adrenal insufficiency enzyme deficiencies are characterized by an enlargement of both the adrenal glands and hyperpigmentation caused by increase in ACTH stimulation caused by decrease in cortisol. Okay, treatment. Glucocorticoids, for example, dexamethasone, medical therapy for adrenal and ovarian disorders, prevents new terminal hair growth but does not resolve hirsutism. Okay. Addition of mineralocorticoids. Corticoid therapy, for example, fludrocortisone, if salt wasting or hypotension is present. Okay, so fludrocortisone is the one we use for mineralocorticoid, dexamethasone for glucocorticoid. Laser ablation, electrolysis, or conventional hair removal techniques for removal of unwanted hair. Polycystic ovarian syndrome. Okay, so mnemonic here is the most severe form of PCOS is Heron syndrome. That's hyperandrogenism, insulin resistance, and acanthosis nigricans. Okay. Polycystic ovarian syndrome, a syndrome of excess testosterone and excess estrogen. PCOS has a prevalence of 6% to 10% amongst US females of reproductive age and is the most common cause of infertility in females. Diagnosis requires fulfillment of two of the following three Rotterdam criteria: oligo-ovulation and/or anovulation, clinical and or biochemical evidence of hyperandrogenism. History and physical examination. Common presentation: obesity, body mass index, BMI, more than 30 kg per m2, menstrual cycle disturbances, infertility, acne, androgenic alopecia, and hirsutism from hyperandrogenism. Females with PCOS also at increased risk for the following: DM type 2 acanthosis nigricans, possibly seen on examination, metabolic syndrome, insulin resistance, atherogenic dyslipidemia, and hypertension. Okay, so BMI more than 30 kg. Okay, you know this. So 6 to 10% is the prevalence. Okay, of reproductive age. Okay, and requires fulfillment of 3 criterias. These are Rotterdam criterias. Polycystic ovaries, got to have that. Oligo-ovulation or aovulation, and clinical or biochemical evidence of hyperandrogenism. Females with PCOS are at increased risk for DM and metabolic syndromes. Okay, common presentation are obesity and acne and hirsutism. Okay, cycle disturbances. Diagnosis. Okay, polycystic ovary and prominent multiple cysts. Okay. All right. So diagnosis: biochemical testing of hyperandrogenemia, increase in testosterone, increase in free testosterone more sensitive than total testosterone. Total can be normal because of low sex hormone binding globulin. Excluding other causes of hyperandrogenism, DHEA is to rule out adrenal tumors. Okay. Pelvic ultrasound to rule out androgen secreting ovarian tumor. 17-hydroxyprogesterone to rule out non-classical congenital adrenal hyperplasia. Screening in the setting of clinical signs of Cushing's syndrome, for example, moon phases, buffalo hump, abdominal stria, or acromegaly, for example, increase in head size. Evaluation for metabolic abnormalities, 2-hour oral glucose tolerance test, fasting lipid and lipoprotein levels, total cholesterol, HDL, LDL, triglycerides, optional tests, not necessary if both oligomenorrhea and signs of hyperandrogenism are present. Okay. So these are transvaginal ultrasonography. Okay. Look for more than 11 small 2 to 9 mm subcapsular follicles forming a pearl necklace sign. See this figure? Seen in roughly 2/3 of female with PCOS. Gonadotropins increase in LH-FSH ratio more than 2 to 1. 24-hour urine for free cholesterol. Adult onset congenital adrenal hyperplasia or Cushing syndrome. Okay, so polycystic ovary with prominent multiple cysts, right? The pearl type thing right there. Treatment: females who are not attempting to conceive. The physician can treat these patients with combined hormonal contraception or progestin, with or without an anti-androgen like spironolactone, if there are symptoms of hyperandrogenism. Patients with metabolic syndrome or insulin resistance may benefit from the addition of metformin. Females who are attempting to conceive, letrozole, aromatase inhibitor, with or without metformin, is first-line treatment for ovulatory stimulation. Clomiphene, selective estrogen receptor modulator, is second line. Okay, so SERM. Okay, so who are attempting, we give letrozole with or without metformin, and first line for ovulatory stimulation. Clomiphene is second line. Okay. Symptom specific treatment: Hirsutism, a combination of OCPs, first-line antiandrogens, and metformin. Obesity, cardiovascular risk factors, and lipid levels. Diet, weight loss can also help regulate ovulation. And exercise plus potentially lipid controlling medication, for example, statins. Okay, complications: infertility, miscarriage, type 2 diabetes mellitus, metabolic syndrome, increase in long-term risk for breast and endometrial cancers because of unopposed estrogen secretion. Okay, key fact here is combined hormonal contraception or progestin decreases the risk for endometrial hyperplasia carcinoma among women with PCOS. Okay. Infertility. So before that, key fact: female causes of infertility are more common than male causes, and investigation should begin with history, including menstrual, and physical examination of the female, and then progress to semen analysis before further workup in the female, as semen analysis is simple and non-invasive. Okay. Infertility. Definition: the inability to conceive after 12 months of regular unprotected sexual intercourse in women less than 35 years of age. The ability to conceive after 6 months of regular unprotected sexual intercourse in women 35 or more years of age. Okay. So inability after 12 months for less than 35, and inability after 6 months for over 35. Okay. So primary infertility characterized by no prior pregnancies. Secondary infertility distinguished by at least one prior pregnancy. Etiologies are shown in this figure and this table. Okay. So this, and that's it. Okay. So we have infertility. The male causes include primary hypogonadism, where you will have increase in FSH 30% to 40% of the time. Secondary hypogonadism, where you will have decrease in FSH and LH 2% of the time. Disordered sperm transport 10% to 20%. Unknown 40% to 50%. Unexplained is 17%, and female causes are 58%. Amenorrhea, ovulatory dysfunction 46%. Okay, tubal defect is 38%. Okay, endometriosis 9%, and others are 7%. In amenorrhea and ovulatory dysfunction, that could be hypothalamic pituitary causes, which is more than half of the time, 51%. Polycystic ovarian syndrome, that's 30%, and premature ovarian failure, that's 12%, and uterine or outflow tract disorder, that's 7%. Okay. All right. So more than half, almost half is amenorrhea ovulatory dysfunction for female causes, whereas in male, which is 25% of the time, it's primary hypogonadism, majority of the time. Okay. So infertility workup. Etiologies: history and physical examination, diagnosis and treatment. Okay. Male factors: testicular injury or infection, medications, corticosteroids, cimetidine, spironolactone, pituitary, thyroid, or liver disease, signs of hypogonadism, varicocele. Diagnosis: semen analysis, TSH, prolactin. You will do all that, and karyotyping to rule out Klinefelter syndrome. Treatment here: treatment of hormonal deficiency, intrauterine insemination, donor insemination, in vitro fertilization, intracytoplasmic sperm injection. Ovulatory factors: history and physical examination, increased incidence with age, symptoms of hyperthyroidism, hypothyroidism, galactorrhea, menstrual cycle abnormalities, pituitary tumors. Diagnoses are menstrual history, basal body temperature, ovulation predictor, mid-luteal progesterone, early follicular FSH with or without estradiol levels, ovarian reserve, TSH, prolactin, and androgens, ovarian sonography, antral follicle count, endometrial biopsies, and luteal phase defect. Treatment here is treatment depends on the etiology, for example, levothyroxine and dopamine. Induction of ovulation with clomiphene, gonadotropins, IUI, and IVF. Okay. Then we have tubal pelvic factors. So history of pelvic inflammatory disease, appendicitis, endometriosis, pelvic adhesions, and tubal surgery. Diagnoses here are hysterosalpingogram, potential laparoscopy. Treatment here is laparoscopic resection or ablation of endometriomas or fibroids, IVF. Cervical factors, cryotherapy, colonization, or diethyl bistro, exposure in utero. Diagnosis, physical exam, treatment, IUI, IVF. And for uterine factors, history and physical examination, polyps, fibroids, congenital anomalies. Diagnosis is with ultrasound and hysterosalpingogram, okay, and surgical treatment for that, okay. So it's pretty straightforward there. You should be able to pick it out in a list of options what the next best step for diagnosis could be, and the treatment is also depending on what the etiology is, okay. Menopause. So cessation of menses for a minimum of 12 months as a result of follicular depletion. History and physical examination. The average age of onset is 51 years. Symptoms include hot flashes, pruritus, vaginal dryness caused by vaginal atrophy, insomnia, anxiety, irritability, poor concentration, mood changes, dyspareunia, and loss of libido. Premature menopause, also known as premature ovarian insufficiency, is cessation of menses before 40 years of age. Diagnosis. A clinical diagnosis. The following studies are not routine but may be helpful. Labs. Increase in FSH, serum TSH, history of serum TSH should be measured because of overlap of symptoms and common age of presentation of hypothyroidism and menopause. Treatment here is best initial treatment, HRT, okay, combination estrogen and progestin, okay, and symptomatic patients without contraindications less than 60 years. So the lab it will show increase in FSH, that's important. Serum TSH should be measured because of overlap of symptoms and common age of presentation for hypothyroidism and menopause. Okay, so HRT, best initial treatments without contraindication for less than 60. Okay, so that is short-term use associated with a decrease in all-cause mortality. Risk-benefit ratio changes based on the individual risk factors when considering continuing therapy long-term. May increase the incidence of breast cancer with long-term use at high doses. May increase cardiovascular mortality if initiated at age more than 60 and or greater than 10 years from the menopausal transition. Contraindications: vaginal bleeding, breast cancer known for suspected, untreated endometrial cancer, history of thromboembolism, chronic liver disease, hypertriglyceridemia, known coronary artery disease. Okay. Non-HRT. For those with contraindications to HRT listed earlier. Selective serotonin reuptake inhibitors, SSRIs, okay, serotonin norepinephrine reuptake inhibitors, SNRIs, clonidine, and or gabapentin to decrease the frequency of hot flashes. Okay, Uh, Topical estrogen preparation, useful for vaginal atrophy. Topical estrogen preparation does not have the same contraindications as systemic HRT. And calcium supplementations with or without bisphosphonate. Okay. Useful for osteoporosis. Uh, DEXA scan is used to measure bone mineral density. Okay, BMD. Supplemental treatment includes daily calcium, vitamin D, and weight-bearing exercise. Okay, key fact here: postmenopausal women should be routinely screened for osteoporosis starting at 65 years of age or earlier, and if there are additional risk factors. All right, okay. So treatment, HRT, right? Contraindications are, you know, vaginal bleeding, breast cancer, untreated cancer, endometrial, history of thromboembolism, liver disease, CAD. Non-HRT treatment would be SSRI, clonidine, that's alpha agonist, uh, right, A2 agonist, and or gabapentin to reduce the frequency of hot flashes. Topical estrogen preparation used for vaginal atrophy. Okay. Um, Topical estrogen preparation, it does not have the same contraindication as the systemic HRT, and then calcium supplements and bisphosphonate for the osteoporosis. Okay. Uh, On to gynecologic disorders, cyst and abscess of the Bartholin duct. Obstruction of the Bartholin duct may lead to cyst formation as mucus continues to accumulate behind the obstruction, causing cystic dilation. An obstructed Bartholin duct that becomes infected can develop a polymicrobial abscess. History and physical examination: cysts 1 to 3 centimeters in size, unilateral, and often asymptomatic. Large cysts lead to periodic painful swelling and dyspareunia. Clinical diagnosis: mass at medial labia majora or lower vestibular area on physical examination. Abscess: extremely painful, warm, fluctuant mass at medial labia majora or lower vestibule with possible cellulitis and fever. Treatment here: asymptomatic cyst, no therapy with or without warm socks. The physician can consider drainage and biopsy if patient more than 40 years of age to exclude carcinoma. Abscess, aspiration or incision, and drainage to prevent reaccumulation. The physician should order tests for gonorrhea and chlamydia and other pathogens. Antibiotics are unnecessary unless cellulitis or sexually transmitted infection is present. Vaginitis: a spectrum of conditions that cause vulvovaginal symptoms such as itching, burning, irritation, and abnormal discharge. The most common causes are bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. Okay. Um, History and physical examination. Uh, Presents with a change in discharge, malodor, pruritus, irritation, burning, swelling, dyspareunia, and dysuria. Normal secretions are follows as follows: mid-cycle estrogen surge, clear elastic mucoid secretions, luteal phase pregnancy, thick and white secretions that adhere to vaginal wall, a thorough examination of the vulva, vaginal walls, and cervix, many WBCs and no organisms on saline smear, suspect chlamydia, trachomitis, and an intracellular organism. Question: a 56-year-old woman presents with presence. Okay, a 56-year-old woman presents with insomnia, vaginal dryness, and lack of menses for 13 months. What is the most likely diagnosis? Probably menopause. The most likely diagnosis is menopause. Menopause is a clinical diagnosis determined retrospectively after 12 months of amenorrhea, without any other obvious physiologic or pathologic cause. However, a physician try to rule out menopause as a cause of secondary amenorrhea may consider ordering a FSH level. Elevation is suggestive of menopause. Okay. Okay. Causes of vaginitis. Okay. And right. So starting with bacterial vaginosis. Okay. Um, Incidence is 15 to 50%. This is the most common. It's not an infection. It's shift. Okay, not an infection. So shift in vaginal flora. Okay, increase in anaerobes such as Gardnerella vaginalis, decrease lactobacilli. Risk factors are pregnancy, multiple sexual partners, female sexual partners, frequent douching. Okay, history is fishy odor than homogeneous white or gray discharge. So fishy odor, thin white, homogeneous or gray discharge. So from sketchy, I remember it was like a fish market when they explained bacterial vaginosis. Okay. Um, right. Examination, mild vulvar irritation, thin homogeneous white or gray discharge. Physical examination, more than 4.5. Discharge, homogeneous, grayish white with fishy stale odor. Wet mount, clue cells, these are the classic presentation. Epithelial cells coated with bacteria, see red arrow in image A. KOH prep, positive whiff test, fishy odor. Treatment, oral, per oral, or vaginal metronidazole, or vaginal clindamycin. Okay. Now complication, chorioamnionitis, endometritis, infection, preterm delivery, and pelvic inflammatory disease. Okay, so these are the clue cells. Okay, so you have a cell and then the bacteria is on the sides. Okay. Then trick. Okay. Trichomoniasis, 5 to 50%. Okay, these are protozoal flagellates and STD. Risk factors, unprotected sex with multiple partners, history, increase in yellow-green discharge. Okay, so remember that. Order, pruritus, dysuria. Examination, classic presentation here is strawberry petechi or petechi. In the upper, is it petechii? I think. In the upper vagina cervix, pH here is 4.5. Discharge, profuse, malodorous, yellow-green, frothy. Okay. Wet mount, you'll have motile trichomonads, flagellated organisms slightly larger than WBCs. See this image. Okay. KOH presentation, not applicable. Treatment, single dose oral metronidazole or tinidazole for both partners. Treatment of partners, otherwise a ping pong effect. Okay. Complications, same as for bacterial vaginosis. Okay. And candidiasis, 15 to 30%. Etiology, usually Candida albicans. Risk factor, DM, antibiotic use, pregnancy, corticosteroids, HIV, OCP use, frequent intercourse, tight-fitting clothing. Okay. History, pruritus, dysuria, burning, cottage cheese discharge. Examination, erythematous excoriated vulva vagina with cottage cheese discharge, pH is less than 4.5. Okay, so there's only one where the pH is less than 4.5, which is normal. In the other two, it's going to be increased. Discharge, thick, white, curdy texture without odor. Wet mount, budding yeast, or hyphae, KOH prep, pseudo hyphae, see this image, and treatment, topical azole or peroral fluconazole. Okay. So for bacterial, it was metronidazole or vaginal clindamycin. For trichomoniasis, it was metronidazole or tinidazole for both partners, single dose, and treatment for both, right? And here for candidiasis, it's topical azole or peroral fluconazole. Okay, so that is budding yeast, right? Or hyphae. All right. Diagnosis, treatment. Vaginal fluid or vaginal pH, amine, whiff test, wet mount with saline and 10% potassium hydroxide, microscopy. A purulent discharge, numerous leukocytes on wet prep, cervical friability, and any symptoms of PID. Nucleic acid amplification test or NAT test, or culture of Neisseria gonorrhea or C. trichomonas to rule out cervicitis. NAT is the gold standard treatment, etiology specific, see that table, okay? So we have vaginal pH, then we check if it's more than 5.5 or less, you know, between 4.0 and 4.5, right? So the normal one was here for less than 4.5, okay? So that would be candidiasis. Okay, so KOH prep, you do that, and then you have negative amine test. Okay, so then we do wet mount. We do wet mount. If it's normal fluid. If you see pseudohyphae, then vulvovaginal candidiasis. If the vaginal pH is more than 4.5, then we do KOH. If it's positive, then wet mount, and then you'll see clue cells compose 20% of the epithelial cells, and that is bacterial vaginosis. If it's negative whiff test, then you mount, and then you'll see motile flagellates, trichomonads, right? That is trichomoniasis. A key fact here, criteria for clinical diagnosis of bacterial vaginosis, 3 of 4 are required, which is abnormal whitish gray discharge, vaginal pH more than 4.5, positive amine whiff test, clue cells composing more than 20% of epithelial cells on wet mount. Okay. So criteria for bacterial vaginosis are abnormal whitish gray discharge. You gotta have 3 of these. So pH, easy to remember. Whiff test, easy to remember. Clue cell, easy to remember. Remember, you also need to have abnormal whitish gray discharge. Okay. On to cervicitis. Cervicitis, inflammation of the uterine cervix. Etiologies are as follows: infectious, most common. C. Chlamydia trachomatis and Neisseria gonorrhea are most common. C. trachomatis is more common than N. gonorrhea in mucopurulent cervicitis. Trichomonas and herpes simplex virus are less common cause of cervicitis. Non-infectious, trauma, radiation exposure, malignancy. All sexually active women less than 25 years of age should undergo yearly screening for C. trichomatis and gonorrhea because of increased rates of asymptomatic infection and increased risk for infertility in untreated infections. Key factor here, genital ulcer. Treponema pallidum causes single painless canker. Hemophilus ducreyi, causes deep, painful ulcers with irregular borders. Ducreyi. Herpes simplex virus causes multiple shallow, painful ulcers. Okay. History and physical examination: mucopurulent, positive, cervical motion tenderness, absence of other signs. Okay. Diagnosis and treatment: relevant discussion of STIs in the renal, genitourinary chapters. Perfect. If mucopurulent discharge is present, empiric treatment for both C. trichomatis and N. gonorrhea is warranted. Question number 1. A 20-year-old woman is diagnosed with trichomoniasis and prescribed an antibiotic. She calls a physician, reporting of flushing, nausea, and emesis. What antibiotic was the patient prescribed and what should she have been warned of? Okay, answer is she was prescribed metronidazole. She should have been warned to abstain from alcohol while taking it, as metronidazole causes a disulfiram-like reaction. Okay. Number two, a 23-year-old woman presents with fever and abdominal pain of 2 days duration. She has a positive cervical motion tenderness. Okay. Antibiotics are started. What is the next step in management? Okay. The next step in management is pelvic ultrasonography to rule out tubo-ovarian abscess. Okay. Pelvic inflammatory disease. PID is a polymicrobial infection of the upper genital tract associated with amenorrhea, 1/3 of cases, C. trichomatis, 1/3 of cases, and endogenous aerobes, anaerobes. Risk factors include uterine instrumentation or procedure, douching, smoking, multiple sex partners, and prior STDs and or PID. Most cases are not secondary to STDs. History and physical examination. Presents with lower abdominal pain, fever, chills, menstrual disturbances, and purulent cervical discharge. Cervical motion tenderness and adnexal tenderness, orogenital contact that can cause gonococcal pharyngitis, along with PID. Diagnosis. Diagnosed by the presence of acute lower abdominal or pelvic pain plus one of the following: uterine tenderness, adnexal tenderness, cervical motion tenderness. First, beta HCG test to rule out pregnancy. Best test is NAT for amenorrhea and C. trichomatis. A WBC count of more than 10,000 cells per microliter. Poor positive and negative predictive values for PID. Ultrasonography, not sensitive or specific, possibly showing thickening or dilation of the fallopian tubes, fluid in the cul-de-sac, a multicystic ovary or tubo-ovarian abscess. Okay. Acute cause of pelvic pain, a rope, A for appendicitis, periumbilical right lower quadrant pain, fever, nausea, vomiting, ruptured ovarian cyst, recent strenuous physical activity, ovarian torsion or abscess torsion, severe unilateral pain, maybe colicky, nausea, vomiting, abscess, gradual onset of fever, vaginal discharge, respectively. PID, gradual onset of fever, vaginal discharge, ectopic pregnancy to be ruled out with beta HCG test. Okay. Treatment. Antibiotic treatment. Okay. Okay. Antibiotic treatment should not be delayed while awaiting culture results. All sexual partners should be examined and treated appropriately. Outpatient regimen. Regimen A: ceftriaxone IM for 1 dose, doxycycline PO for 14 days. Okay, so triaxone for 1 dose IM and doxycycline for 14 days, with or without metronidazole per oral for 14 days as well. So metronidazole covers anaerobic infections. Regimen B is ofloxacin or levofloxacin for 14 days, with or without metronidazole for 14 days. This is only in special cases because there is an increase in quinolone-resistant amenorrhea. Treatment should not be delayed for NAT. Inpatient antibiotic regimen is cefoxitin or cefotitan, plus doxycycline for 14 days. Clindamycin plus gentamicin for 14 days. Okay. Additional intervention. Drainage of a tubo-ovarian pelvic abscess is appropriate if mass persists after antibiotic Treatment: abscess is more than 4 to 6 centimeters, or mass is in the cul-de-sac in the midline and drainable through the vagina. If the patient's condition deteriorates, the case calls for exploratory laparoscopy or laparotomy. Surgery may range from total hysterectomy and bilateral oophorectomy with lysis of adhesions. In severe cases, the conservative surgery for females who desire to maintain fertility. Key fact: mild and subclinical PID are major causes of tubal factor infertility, ectopic pregnancy, and chronic pelvic pain caused by pelvic scarring. Complications: repeated episodes of infection, chronic pelvic pain, dyspareunia, and ectopic pregnancy. Infertility: 10% after the first episode, 25% after the second episode, and 50% after the third episode. Fitzhugh-Curtis syndrome presents with associated perihepatitis, right upper quadrant pain, abnormal liver function, and referred right shoulder pain. Ovarian torsion: twisting of the ovary, vesicle peduncle, that occludes venous and or arterial flow to the ovary, leading to ischemia. History and physical examination: colicky lower quadrant abdominal pain of the acute onset with peritoneal signs, nausea, and vomiting. Risk factors include PCOS and ovarian tumors and cysts. Most common times for torsion in pregnancy: 18 weeks gestation when the uterus is rising over the pelvic brim, or immediately postpartum with uterine involution. The increased motion of the uterus at these times increase the risk for torsion. Diagnosis: best initial test: ultrasound with Doppler may show ovarian abnormal venous or arterial flow. CT can help with visualization of an ovarian mass or cyst, but will not provide information on blood flow to the ovary. False negatives are possible due to intermittent torsion. If suspicion persists following a negative ultrasound, surgical evaluation is indicated. Treatment here is laparoscopy or laparotomy with distortion if the ovary is still viable, or oophorectomy if not viable. Pediatric vaginal discharge. Etiologies of vaginal discharge is in pediatric patients include the following: foreign objects, most common cause of vaginal discharge in pediatric patients. Infectious with vulvovaginitis. Okay. Um, may present with a malodorous yellow-green purulent discharge. Causes include the following: group A streptococcus, the most common infectious cause; Candida, that's recent antibiotic therapy; immunosuppression, for example, diabetes, rare in children; STIs, typically for sexual abuse; non-infectious vulvovaginitis. Potential causes include poor hygiene, contact dermatitis, and eczema; sarcoma Botrytis or rhabdomyosarcoma, a malignancy with lesions that have the appearance of bunches of grapes within the vagina. Key fact: pediatric vaginal discharge may be normal, but STDs resulting from sexual abuse must be ruled out, and if found, report to Child Protective Services. Okay. So for torsion, just want to confirm what we do for that. We'll do ultrasound with Doppler. Okay. Show abnormal venous and arterial flow. CT can also help with visualization, but if you have ultrasound, we'll do that. And false negative possible due to intermittent torsions. Okay. Toxic shock syndrome, caused by a reaction to toxic shock syndrome. Toxin 1, a preformed Staphylococcus aureus toxin. It's preformed. Okay. Menstrual cases occur due to retained tampons used for longer than recommended. Non-menstrual cases are nearly as common as menstrual cases and occurs in the setting of surgical wounds and burns. History and physical examination. Presents with abrupt onset of fever, vomiting, and watery diarrhea, a diffuse macular erythematous rash involving the Palms and soles, non-purulent conjunctivitis, common, desquamation, especially of the palms and soles, generally occurring during recovery within 1 to 2 weeks of illness. Diagnosis: based on the clinical presentation, fever more than 102, hypotension, skin findings, involvement of 3 or more organ systems, negative blood cultures, given that the TSS is caused by a preformed toxin and not invasive properties of the organism. Key fact: TSS is a rare but potentially fatal reaction to S. aureus toxin, not to the bacterium itself. Treatment here: rapid rehydration, examination of for foreign objects in the vaginal canal, drainage if localized infection found, empiric antibiotics, clindamycin, vancomycin. Clindamycin is used for its antitoxin properties. If methicillin sensitive S. aureus isolated in wound, clindamycin, oxacillin, or neficillin. Okay. Um, right. Okay. If methicillin resistant S. aureus isolated, then clindamycin plus vancomycin or linezolid. Okay. So neficillin is safe for SA. Okay. And oxacillin, clindamycin. Okay. And empiric antibiotic is clindamycin, vancomycin. Clindamycin used for its antitoxin properties. Okay. All right. Complications: mortality rate associated with TSS is 3% to 6%. Causes of death include cardiac arrhythmias, cardiomyopathy, respiratory failure caused by acute respiratory distress syndrome, and coagulopathy caused by disseminated intramuscular coagulation. Okay. Benign breast disorders. Non-proliferative breast lesions. Generally no increased risk for breast cancer. Simple breast cysts are the most common. They are fluid-filled mass stemming from an exaggerated stromal tissue response to hormones and growth factors. Okay, so there's fat necrosis of the breast, benign condition that presents radiologically like breast cancer, but the breast biopsy reveals fat globules. No further workup indicated. Secondary to trauma to the breast or caffeine use. Typically females 30 to 50 years of age develop non-proliferative breast lesions. Postmenopausal females rarely develop them. Provide reassurance and pain control. Fibrocystic cystic changes of the breast. This is benign condition that presents as bilateral breast tenderness with diffuse cord-like thickening of the breasts with no discharge. Cord-like thickening of breast with no discharge. Tenderness worsens during menstruation. Okay. Okay, and this was just okay. Fibroadenoma. This is benign condition that presents as solitary, mobile, well circumscribed nodule. Tenderness and size increase during menstruation. Classically seen in women less than 30 years of age. Provide reassurance and pain control. Discuss more later. History and physical examination. Cyclic bilateral mastalgia and swelling. Most prominent just before menstruation. Rapid fluctuation in size of masses, a common finding. Key fact: the differential diagnosis of a breast mass includes fibrocystic disease, breast cyst, fibroadenomas, mastitis, abscess, fat necrosis, and breast cancer. Okay, so diagnosis: see this figure for an algorithm for a breast workup. First, have patients return after menstruation because symptoms fluctuate with hormones. Best initial test: if unchanged on follow-up, perform ultrasonography to differentiate a mass from fluid-filled one versus a solid one. So we do US, okay. So breast mass, history and breast examination to assess risk. Asterisk is suspicious features, age more than 35, family history of cancer, firm non-mobile mass, axillary adenopathy, skin changes. Skin does not change with menstrual cycle. Okay. So then, if it's not suspicious for cancer, we do ultrasound. If it's intermediate indeterminate lesion and it's someone that's less than 30 years of age, then ultrasound plus diagnostic mammogram. If it's someone over the age of 30, then diagnostic mammogram plus ultrasound. Okay. And suspicious of cancer, then diagnostic mammogram plus core or excisional biopsy. Ultrasound. Okay. Fine needle aspiration, follow up in 2 to 3 months. Okay, simple cyst. Biopsy, fine needle aspiration or core needle, and cytology. Lesions not visualized, complex cyst or solid mass. Okay. Repeat biopsy, inadequate sample. Okay. Benign, reassurance, routine follow-up, atypical cells, excisional biopsy. And if you have DIC or malignancy, treat it as indicated. Okay. Subsequent test. Okay, so we're on non-proliferative breast lesions. Okay, we're discussing diagnosis. Subsequent test: fine needle aspiration (FNA) of a discrete mass that is suggestive of a cyst is indicated to alleviate pain and to confirm the cystic nature of the mass. Most accurate test: excisional biopsy is indicated if no fluid is obtained or if the fluid is bloody on aspiration. Mammography is of limited use, especially if less than 35 years of age, because of density of breast tissue. There is no increased risk for breast cancer if patient has a simple cyst, but there is increased risk if patient has a complex cyst, ductal epithelia hyperplasia, or cellular atypia, which is rare. Key fact here: intraductal papilloma and mammary duct ectasia are common cause of bloody nipple discharge. Okay, so most accurate test. Subsequent test is FNA of a discrete mass, suggestive of cyst, to alleviate pain, confirm cystic nature of the mass. Most accurate test is excisional biopsy is indicated if no fluid is obtained or if the fluid is bloody on aspiration. Okay, so we do FNA and then inadequate sample and repeat biopsy. If it's benign, reassurance and routine follow-up, atypical, excisional. Okay. Proliferative breast lesion without atypia include intraductal papillomas, sclerosing adenosis, and usual ductal hyperplasia, associated with a small increased risk for breast cancer. An intraductal papilloma is composed of papillary cells growing from the wall of a cyst into the lumen. Diagnosis: these lesions are diagnosed with core needle biopsy. Surgical excision is required to exclude atypia and ductal carcinoma in situ (DCIS). Treatment: sclerosing adenosis and usual ductal hyperplasia require no treatment. Intraductal papilloma: papillary tumor affecting a single lactiferous duct. It is the most common cause of blood discharge in middle-aged women. Okay. Just going with it. Papillary cells growing from the wall of the cyst into the lumen. Okay. And this one is papillary tumor, intraductal. Most common cause of bloody discharge. Okay. History and physical examination presents as unilateral bloody discharge from nipple in 40 to 50 years old female. Diagnosis: obtain breast ultrasound or mammography. Decision based on age of patient. Obtain a needle biopsy or FNA. Treatment: excision is curative. Question: a 30-year-old woman was in car accident 1 week ago, and subsequently noticed a hard bump in the left breast. What is this likely to be, and what can be found on biopsy? Okay, fat tissue necrosis. I think that's what they're going for. This is necrosis. This is fat necrosis of the breast. Okay. The this commonly occurs after trauma that is not always remembered. It is a mimicker of breast cancer in terms of presentation and radiographic findings. Biopsy results differentiate the two and reveal coarse, not micro, calcifications and foamy macrophages. Another one. A 27-year-old woman palpates a 1 by 1 new breast mass on self-examination. What is the first step in the workup of the mass? Okay, ultrasonography. The patient is less than 30 years of age, so ultrasonography is the preferred means of distinguishing a solid mass from a cyst. I believe you go to mammography after 35, as we read up here, or after 30. Okay, so less than 30 ultrasound, after 30 mammogram. Okay. Phylloid tumor. Okay, so this is phylloid tumor with classic leaf-like appearance. Okay, looks like a leaf. Okay, so can sometimes be difficult to distinguish from a fibroadenoma. It is generally larger and greater metastatic ability, and the differentiating features are the papillary projections of the stroma lined with epithelium and associated with a hyperplasia and atypia. Phylloid tumors should be completely excised. Axillary lymph node dissection is not necessary. Atypical hyperplasia. Atypical hyperplasia can be ductal or lobular, filling part of but not the entire duct or lobule, similar to low-grade DCIS or lobular carcinoma in situ, with a moderately increased risk for breast cancer. Okay, but not the entire filling part. Okay, right. Found incidentally in biopsy done after a suspicious mammogram. Okay, requires risk reduction, which involves yearly mammograms and tamoxifen or aromatase inhibitor if postmenopausal. Okay. Mnemonic here is common metastasis. Did I miss any here? So mnemonic, common metastasis to bone is BLT and kosher pickle on top. So to bone, it's breast, lung, thyroid, and then kidney, prostate cancer. Okay. And key fact, hormone containing contraception is contraindicated in patients with breast cancer. The safest option for contraception is copper IUD. Alright, so breast cancer. The most common cancer affects 1 in 8 women, and the most common cause of cancer death in females. After lung cancer in the United States, 60% occur in upper outer quadrant. One half of newly diagnosed patients have risk factors. Risk factors include the following: female sex, older age, above 40 years of age, a personal history of breast cancer, family history is in a first degree relative, genetic factors like BRCA1 and BRCA2 mutations. Associated with early onset. Alcohol, cigarettes, controversial exposure to radiation, a history of fibrocystic changes with cellular atypia, increased exposure to estrogen, nulliparity, uh, early menarche, late menopause, first full term pregnancy after 35 years of age, PCOS, HRT. History and physical examination. Clinical manifestations include the following: early findings: single, non-tender, immovable, firm to hard mass with ill-defined margins or mammographic abnormalities on routine screening. Later findings: locally advanced. Axillary lymphadenopathy, breast enlargement, pain, peau d'orange, skin finding suggesting inflammation, redness, thickening, dimpling, fixation of the mass to the skin or chest wall, prolonged unilateral scaling, erosion with eczematous rash of the nipple that spreads to the areola with or without discharge, Paget's disease of the Paget disease of the nipple, specific for DCIS. Okay. So prolonged unilateral scaling, erosion with eczematous rash of the nipple that spreads to the areola with or without discharge. Late findings: ulceration, supraclavicular lymphadenopathy, edema of the arm, metastatic disease, metastasis to the bone, lung, and liver, pain, bone pain, lung, dyspnea, cough, and liver, abdominal pain, nausea, jaundice. A firm or hard axillary node more than 1 centimeter. Axillary nodes that are matted or fixed to the skin. Stage 3, ipsilateral, supraclavicular or infraclavicular node is considered stage 4. Okay, so axillary node matted or is fixed to the skin is stage 3. Ipsilateral, clavicular, or infraclavicular nodes, stage 4. Okay. This is breast cancer, mediolateral oblique, so that's what that looks like. Okay. And craniocaudal view of the mammogram demonstrates a speculated mass with a satellite mass in the central and outer upper right breast. A targeted breast ultrasonogram, C, in a different patient demonstrates a hypoechoic mass and is taller than it is wide and exhibits dense posterior acoustic shadowing. Okay. Key fact: the first step in the workup of a suspicious mass in postmenopausal female and in those more than 30 years of age is a mammogram. For premenopausal females less than 30 years of age, the first step should be an ultrasound. The diagnosis: majority of breast cancers diagnosed from mammography. Screening: postmenopausal women, mammography. The physician should look for increased density with microcalcification, irregular borders, and speculated mass. Mammography can detect lesions roughly 2 years before they become clinically palpable. Premenopausal women, ultrasonography for female less than 30 years of age because of density of breast tissue can distinguish a solid mass from a benign cyst. Women with the following risk factors are recommended by the American Cancer Society to undergo annual MRI screening. Known BRCA mutation, first degree relative who is a BRCA carrier, lifetime risk for breast cancer that is 22% to 25% or greater. Biopsy of suspicious lesions on mammography. A mammography guided FNA or core needle biopsy, a full thickness skin biopsy, should be done if signs of inflammation are present. FNA, a good initial biopsy, especially for lesions close to the skin. However, it is a small sample with a high false negative rate. FNA may also be used to follow response to a treatment. Core needle biopsy, a larger sample that allows testing for receptor status. Open biopsy, less commonly used, it provides tissue for a more accurate diagnosis and allows immediate resection of tumor. However, an open biopsy requires taking the patient to operating room. Okay. Receptor status of tumor, determination of estrogen receptor, progesterone receptor, and human epidermal growth factor 2 or HER2 status. Tumor markers for recurrent breast cancer, typically used for metastatic disease as a proxy to monitor treatment response, include carcinoembryogenic antigen and cancer antigen 15-3 or 2729. C2729. Okay. So 15-3 or 27-29. Breast cancer stages. Primary tumor sizes less than 1, less than 2. Okay. There's no nodal involvement, and there are no distant metastases. Okay. Oh, they're talking about that. Okay. So if it's less than 2, it's stage 1. For stage 2, it has to be 2 to 5 centimeters. Okay. Um, okay. And tumor more than 5 centimeters as stage 3, and for 4, extension chest wall skin. Okay. Regional lymph nodes. N 0. No nodal involvement. 1. Movable ipsilateral axillary lymph nodes. 2. Fixed ipsilateral axillary lymph node. 3. Is ipsilateral supraclavicular lymph node or clinically detected lymph node with axillary lymph node. Okay, so 0, no nodal. 1, it's movable ipsilateral axillary node. 2, it's fixed. 3, and now it has it's involved supraclavicular and lymph node or clinically detected lymph node with axillary lymph node. And then metastasis is no distant metastasis, and 1 is distant metastasis. Okay, so metastatic disease, imaging, X-ray of the chest, CXR, CT of the chest, abdomen and pelvis, brain MRI. Positron emission tomography, PET, and bone scans can be useful. Treatment, early stages. Breast conserving surgery plus radiation or mastectomy, with or without radiation, if cancer is deep margins or axillary lymph nodes. In both cases, the situation also calls for sentinel node biopsy for evaluation of axillary lymph node. Adjuvant therapy as indicated. Okay, locally advanced neoadjuvant chemotherapy plus HER2 directed therapy to reduce size of tumor to allow for breast conserving therapy as opposed to mastectomy. Breast conservation surgery or mastectomy with sentinel lymph node biopsy. Adjuvant therapy as indicated. Okay. Adjuvant therapy. All ER/PR positive patients should receive tamoxifen, a selective um, receptor modulator or SERM that competitively antagonizes the ER. Okay, so for ER/PR positive, we give tamoxifen. It competitively antagonizes the ER receptor, inhibiting the growth of the breast cancer cells. Or an aromatase inhibitor if postmenopausal inactivates aromatase that converts peripheral androgens to estrogens. All HER2 positive patients should receive HER2 directed therapy such as trastuzumab, a monoclonal antibody that binds to HER2 receptors on the cancer cells. Watch for cardiotoxicity. ER/PR and HER2 negative patients should receive chemotherapy if tumor is more than 0.5 centimeters. Contraindications to breast conserving therapy, lumpectomy. Okay. Large tumor size, subareolar location, multifocal tumors, fixation to the chest wall, prior radiation to the chest wall, or involvement of the nipple or overlaying skin. Stage 4 disease, treated with radiation therapy, hormonal therapy, and biologic therapy, depending on the receptor status of the tumor. This table describes the breast cancer stages. Okay. Key fact: In a postmenopausal woman with a new breast lesion, the physician should maintain a high degree of clinical suspicion of breast cancer. Key fact: tamoxifen use is associated with hot flashes, endometrial cancer, and venous thromboembolism because it has mixed antagonists, which is breast, and agonist endometrium activity on estrogen receptors. Okay. Key fact: stage 2 of the breast cancer is associated with tumor size more than 2 centimeters. Stage 3 is associated with nodal involvement, and stage 4 is associated with metastasis. Okay, so prognosis: TNM staging 1 to 4 is the most reliable indicator of prognosis. Positive ER status and PR status are associated with favorable prognosis. Cancer localized to the breast has a 75% to 90% cure rate, with spread to the axilla. The 5-year survival rate is 40% to 50%. Complications: pleural effusion is common in patients with metastatic breast cancer. Edema of the arm is most common secondary to nodal involvement. Okay. Edema of the arm. Okay, so pleural effusion is common in patients with metastatic breast cancer. Edema of the arm is common secondary to nodal involvement. Okay. Key fact: inflammatory breast carcinoma is rare, but it is aggressive. It is an aggressive cancer that presents with pseudo-orange skin, edematous cutaneous thickening, along with a red and painful breast cancer. Axillary lymphadenopathy is typically present. Benign gynecologic disorders. Okay. Uterine leiomyomas or fibroids. Fibroids are the most common benign neoplasms of the female genital tract. They present as singular or multiple discrete round and firm tumors. Composed of smooth muscles and connective tissues, fibroids may cause infertility and amenorrhea. Fibroids are hormone sensitive. Skin size will increase in pregnancy, decrease after menopause. Malignant transformation to leiomyosarcoma is rare, 0.1% to 0.5%. Prevalence more common in black females, 50%, than in white females, 25%. Key fact here is an irregular and mobile uterus is the key physical examination finding for fibroids. Okay, so history and physical examination, majority of cases are asymptomatic. Symptomatic patients may present with the following: bleeding, longer, heavier bleed periods, anemia. Mass effect: pelvic rectal pressure, constipation, and urinary frequency and retention pain. Secondary dysmenorrhea, dyspareunia. I'm sorry about that pronunciation. um, pelvic symptoms: a firm, non-tender, irregular, enlarged, lumpy, bumpy, or cobblestone uterus may be felt on physical examination. Okay, so they said here that irregular and mobile uterus is the key physical examination finding of for fibroids. Another key fact: if a uterine mass continues to grow after menopause, suspect malignancy. Diagnosis: physical examination, ultrasonography, or transvaginal to look for uterine myomas. Can also exclude ovarian masses. Calcification indicates necrosis. MRI can delineate intramural, subserosal, and submucosal myomas. The best modality for visualization, MRI, is usually reserved in preparation for surgery or if there is concern for leiomyosarcoma, a new or growing mass in postmenopausal female. CBC to assess for anemia. Treatment: if asymptomatic, expectant management and annual pelvic exams and CBCs as needed. Pharmacologic: combined hormonal contraception, medroxyprogesterone acetate or danazol to slow or stop bleeding. GnRH analogs, leuprolide or naproxen interferon to decrease the size of myomas, suppress further growth, and reduce surrounding vascularity. Okay, these also may be used before surgery to decrease uterine size, help with anemia, and also allow a minimally invasive approach to hysterectomy. NSAIDs for pain. Surgery. Females of childbearing years, abdominal or hysteroscopic myomectomy. Females who have completed childbearing, hysterectomy. Okay. Oh, abdominal or hysterectomy. Okay, hysterectomy with myomectomy. Okay. Uterine artery embolization, approximately 25%, will need further invasive treatment. Emergent surgery may be required if torsion of a pedunculated myoma occurs. Okay. Complications. Infertility may be caused by myoma that distorts the uterine cavity and plays a role similar to that of an IUD. Non-neoplastic ovarian cysts. Non-neoplastic cysts are the most common cause of ovarian enlargement. See this table. Ovarian lesions are more likely to be benign if unilateral, simple, smaller than 8 centimeters, and in women less than 45 years of age. Malignant ovarian lesions are discussed in detail later in this chapter. Okay. This chapter just doesn't seem to end. Common benign ovarian cyst, non-neoplastic type, and information. Okay, so we have follicular ovarian cyst, physiologic cyst. Okay, it occurs when follicle develops into maturity and does not rupture to release ovum. Okay, corpus luteal cyst. Corpus luteum fails to involute and continues enlarging post-ovulation. And theca cyst, it occurs from overstimulation from hormones, HCG. And luteoma, non-neoplastic ovarian mass associated with pregnancy, maternal hirsutism, and virilization. Okay, so you get that from that. Okay. Key fact: vaginal bleeding is present in 80% of women with endometrial carcinoma, but only 5% to 10% of women with abnormal vaginal bleeding have endometrial cancer. Okay, so what? Okay, so all 80% of all endometrial carcinoma will have vaginal bleeding, but not all vaginal bleeding is endometrial carcinoma, is what they're saying. Okay. Okay, so gynecologic neoplasms. Gynecologic cancers include uterine, endometrial, ovarian, cervical, and valvular neoplasms. Ovarian cancer carries the highest mortality. Endometrial cancer, type 1 adenomatroid adenocarcinomas, derive from atypical endometrial hyperplasia and are the most common female reproductive cancer in the United States. Type 2 cancer derived from serous or clear cell histology, see this table. Although type 2 cancers tend to be more aggressive, diagnosis and management are similar for both types. Type 1 is the most curable gynecologic cancer. So type 1 from endometrioid adenocarcinomas derived from atypical endometrial hyperplasia. Okay, is the most common type. And type 2 is derived from serous or clear cell histology. Okay. History and physical examination, vaginal bleeding. Early finding, pain is late finding. Okay. And diagnosis is sorry about that. No, diagnosis: first physical examination and pregnancy test if premenopausal. Second, ultrasonography. If postmenopausal, can do transvaginal and evaluate endometrial strip uh, less than 4 mm, unlikely to be endometrial cancer. Ultrasonography shows thickened endometrium and hypertrophy and neoplastic changes in very advanced cases. Finally, endometrial biopsy. If patient is postmenopausal with recurrent and persistent bleeding, a biopsy is necessary regardless of ultrasonography results. Okay. So first you do the pregnancy test, then you do the ultrasonography. If postmenopausal, you can do transvaginal or uh, evaluate endometrial strip. Okay. Ultrasonography shows thickened endometrium. Okay, with hypertrophy and neoplastic changes. Okay, and that. Okay. Treatment: high dose progestin for women who desire future fertility. Hysterectomy and BSO with or without radiation for postmenopausal women. Hysterectomy and BSO with adjuvant chemotherapy and or radiation for advanced stage cancer. Which BSO? Did I miss that somewhere? I have no idea what BSO means. Anyways, moving on. Key fact: when to perform a biopsy for endometrial cancer? Postmenopausal, endometrial strip more than 4 mm, or any recurrent or persisting bleeding, spotting regardless of ultrasound results. And premenopausal, sustained intermenstrual bleeding, menorrhagia, or amenorrhea after initial workup and in the setting of unopposed estrogen, obesity, and DM. Okay. Types of endometrial cancer: variable, type 1 endometrioid, and type 2 serous. Epidemiology: 75% of endometrial cancers, 25% of endometrial cancers in type 2. Okay. For type 1 endometrioid, etiology: unopposed estrogen stimulation, for example, obesity, tamoxifen use, exogenous estrogen only therapy. Precursor lesions are hyperplasia and atypical hyperplasia. Mean age at diagnosis 55 years. Prognosis is favorable. In type 2, the serous type, okay, 25% of endometrial cancers. Etiology is unrelated to estrogen p53 mutation, presents in 90% of cases. Precursors lesion, none. Mean age at diagnosis 67 years. Prognosis poor. Okay, here we have endometrial cancer. Okay, sagittal endovaginal ultrasonogram demonstrates a mass in the lower uterine segment of the endometrial canal with fluid distending the canal into the fundus. Gross specimen from a different patient shows a large mass filling the endometrial canal and invading the myometrium. Cervical cancer: the endocervix lies proximal to the external OS, is non-visible, and is composed of columnar cells, similar to the lower uterine segment. The ectocervix is visible and composed of squamous cells, similar to the vagina. The exposure of columnar cells to an acidic vaginal pH results in metaplasia to the squamous cells. The normal squamo-columnar junction transformation zone is in the ectocervix and can be exposed to carcinogens, resulting in cervical intraepithelial neoplasia, and abnormal proliferation of or overgrowth of the basal cell layer. Human papillomavirus (HPV) DNA is found in 99.7% of all cervical carcinomas. HPV-16 is the most prevalent type in squamous cell carcinoma. HPV-18 is the most prevalent in adenocarcinoma. Okay, so 16 is squamous. Okay, and 18 is adeno. Okay. Additional risk factors include immunosuppression, infection with HIV, or a history of STIs, tobacco use, or high parity. HPV vaccine protects against 9 different pathogenic strains, including HPV type 6 and 11, cause 90% of genital wart, and 16 and 18 cause 70% of cervical cancer. The vaccine is recommended for males and females 11 to 26 years of age and may be considered in certain high-risk patients up to 45. Okay. Classification of pap smears. Okay, so benign. Benign is negative. Okay, so cervical intraepithelial neoplasia is the histologic calcification. The Bethesda system is used for reporting cytologic diagnosis. So benign is negative. Benign with inflammation is ASC-US or ASC-H. Sin 1 is L-cell, Sin 2 is H-cell, and Sin 3 is H-cell. Invasive cancer is invasive cancer. Bethesda, okay, remember that. History and physical examination, intermenstrual bleeding, postcoital spotting, and cervical ulcerations are the most common signs. Bloody or purulent, malodorous, non-puritic discharge may appear after invasion. Screening. The American College of Obstetricians and Gynecologists currently recommend the screening for cervical cancer begin at 21 years of age, regardless of onset of sexual activity. Screening recommendations for female with previously normal examinations: 21 to 29 years of age, pap smear, cytology every 3 years; 30 to 65 years of age, pap smear every 3 years, or co-testing pap smear with plus HPV test every 5 years. Okay, so every 5 years with those two. Okay, and every 3 years. From 21 to 29, 32, 35 every 3 years or 5 years. Okay. 65 years of age, stoppage of screening if prior tests were negative. See this table for classification system of pap smear. Alternative screening strategy using primary HPV testing to triage who should have a pap smear. Okay, so see this figure. Female with DES exposure, risk for clear cell cancer and or immunocompromised status, including HIV positivity, should continue to be screened as long as they do not have a life-limiting condition. Females with HIV should be screened with cytology twice in their first year after diagnosis and then annually. See what? Females with HIV should be screened twice first year after diagnosis. Okay. 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 So less than 21 years. What is this? Pap smear recommendations by age and HPV screening strategy. So basically what we just read in a diagram. So less than 21 years, nothing recommended regardless of sexual activity. 21 to 29 is 3 years, pap smear every 3 years. 32 to 65 is 3 years or 5 years if with HPV. Pap smear every 3 years preferred, or co-test every 5 years, or HPV test every 5 years. Okay. Was asterisk? They did not explain it. Oh, they did. Co-test HPV plus pap smear. Okay. And more than 65, stop it if everything was negative. Nothing more than Sin 2. Within 25 years and negative screening in prior 10 years. USPSTF and AAFP guidelines. Okay, so USPSTF is US Preventive Science Task Force Services, Preventive Services Task Force, and AFP is American Academy of Family Physicians. Diagnosis. See algorithm in this application of the information and determine management. Low-grade squamous intraepithelial lesion. Low-grade squamous intraepithelial lesion. LSO. Okay. PAP. That was also was the Sin 1, 2, and 3. Okay. Repeat pap smear at 12 months. If negative times 2, then routine screening. Atypical squamous cells of undetermined significance. Okay, so atypical squamous cell of undetermined significance depends on co-testing. Colposcopy if positive high risk HPV. High grade squamous intraepithelial lesions. Okay, colposcopy. Treatment here is for invasive disease. Treatment is based on likelihood of progression to cervical cancer and patient's age. Desire for future childbearing is as follows. Sin 1, observation with yearly pap smears versus ablative therapy when done with childbearing. If Sin 2, then observation or ablative excisional therapy depending on childbearing status. And Sin 3 is excisional therapy. Post-evolution and excisional therapy follow-up is Sin 1 or Sin 2 or 3 with negative margins, pap smear at 12 months and or HPV testing. Sin 2 or 3 with positive margins, pap smear at 6 months, consider repeat endocervical curage. Treatment based on biopsy results for invasive disease is as follows. For staging, see this figure. Microinvasive carcinoma stage this. Treat with cone biopsy and close follow-up or simple hysterectomy. Stage IB2, IB1, IB2, IA2A. Oh, okay. Stages 1A2, 1B1, 1B2, 2A. May be treated either with radical hysterectomy or with radiation therapy plus chemotherapy. And stage 2B, 3, and 4, treat with radiation therapy plus concurrent cisplatin based therapy. So in this, we do radical hysterectomy, okay, or with radiation therapy plus chemotherapy. Here we do radiation therapy plus concurrent chemotherapy, cisplatin based. Okay, for 2B, 3, and 4. Okay, and okay, so we have stage extent of the tumor in stage 0. It's carcinoma in situ. 5-year survival is 93%. Stage at presentation is nothing, I guess. Okay, now so staging of cervical cancer. Anatomic display of the stages of cervical cancer defined by location, extent of tumor, frequency of presentation, and 5-year survival. Okay. Stage 1, confined to cervix and or uterus, IE 93, I1A 93%, and 1B 80%. Stage at presentation is 47% of survival. Okay, so you have fundus, uterine, and all that stuff. Here we have 1A is here, and then if it travels upwards, then that's 1B. Okay. Stage 2. Okay, so that's 2A now that it's upwards and downwards. It's traveled. 2A. Okay, but it hasn't reached this, I guess. The line between. Okay, so that's 2B. That's 2A going downwards. Okay, so if it's going downwards, it's considered A. And if it's going upwards, it's considered B. And depending on the length, it's 1, 2, or 3. And that rhymed. Look at me. Okay, so 2B, pelvic side. Okay, and then 4A is a mess all over the place. Okay, and 4B is if it travels down to the nearby organs. Okay. Stage 2 spreads beyond uterus, but not to pelvic wall or lower 1/3 of the vagina. 2A 63%, 2B is 58%, and stage at presentation is 28%. Stage 3 spreads to pelvic sidewall, okay, and or lower 1/3 of the vagina. Okay. So yeah, okay. 2A 35%, 2B 32%, 21% of stage at presentation. Stage 4, it invades the bladder, rectum, and distant metastasis beyond the true pelvis. 5-year survival is 16% for 4A, okay, and 15% for 4B, and stage at presentation is 4%. Prognosis: 5-year SOA rate are inversely proportionate to the stage of cancer, so higher this stage, lower the survival rate, with stage 1A having more than 95% and stage 4 having less than 20%. For cancer, risk factors include HPV type 16, 18, and 31, lichen sclerosis, diabetes, obesity, hypertension, cardiovascular disease, smoking, high risk sexual behavior, and immunosuppression. Valvular intraepithelial neoplasia, WIN, is precancerous and is more commonly found in premenopausal women. History and physical examination. Okay. Uh, Presents with pruritus, pain, or ulceration of the mass. Additional symptoms that include the following: early, lesions that appear white, pigmented, raised, thickened, nodular, or ulcerative. Late, presents with a large and cauliflower-like or hard and ulcerated area in the vulva. Diagnosis: vulvar punch biopsy for any suspicious lesions or persistent valvular pruritus, especially in postmenopausal patients. Treatment: high grade WIN. Okay. Um, Topical therapy: chemotherapy, laser ablation, wide, local excision, skinning vulvectomy, and simple vulvectomy. Invasive, then radical vulvectomy and regional lymphadenectomy. Wide local excision of the primary tumor with inguinal lymph node dissection with or without preoperative radiation, chemotherapy, or both. Vaginal cancer accounts for 1% to 2% of all gynecologic malignancies. Risk factors include immunosuppression, chronic irritation, for example, long-term pessary use or prolapse, or female organs, low socioeconomic status, radiation for cervical cancers, hysterectomy for dysplasia, multiple sexual partners, and DES. Exposure etiologies are as follows: postmenopausal females, usually squamous cell carcinoma; younger females, usually other histologic types, for example, adenocarcinomas, clear cell adenocarcinoma from DES. History and physical examination presents with abnormal vaginal bleeding, abnormal discharge, or postcoital bleeding found in the upper third of the vagina in 75% of patients. The diagnosis, definitive diagnosis, is with biopsy and staging. Treatment: local excision of involved area when they are few and small. Partial or complete vaginectomy, if extensive involvement of the vaginal mucosa, radiation therapy, or radical surgery; if invasive disease. Ovarian cancer. Most ovarian tumors are benign, but malignant tumors are the leading cause of death from reproductive tract cancer. There is no screening test for ovarian cancer. Risk factors include the following: age, low parity, decreased fertility, or delayed childbearing. Um, Positive female history. Patients with one affected first degree relative have a 5% lifetime risk, with two or more affected first degree relatives. The risk is 7%. Genetics: the BRCA1 mutation carries a 45% lifetime risk for ovarian cancer. The BRCA2 mutation is associated with a 25% lifetime risk. Lynch 2 syndrome, also known as hereditary non-polyposis colorectal cancer, HMPCC. It is associated with the increased risk for colon, ovarian, endometrial, and breast cancer. OCPs taken for 5 years or more decrease risk for 29%. By 29%. Okay. I'm gonna have to do those markers as well. Okay. All right. History and okay, key fact: frequency of female genital tract cancer, endometrial more than ovarian, more than cervical. Number of deaths: ovarian more than endometrial and cervical. Okay, so for cancer, the frequency is more for endometrial, and then ovarian, and then cervical, and the number of deaths are due to ovarian more than endometrial, which is and more than cervical. So cervical has lowest frequency and lowest number of death. However, more number of death is in ovarian and more frequency is in endometrial. Okay. History and physical examination for ovarian cancer. Both benign and malignant ovarian neoplasms are Generally asymptomatic, mild non-specific gastrointestinal symptoms or pelvic pressure pain may be seen. Early disease is typically not detected on routine pelvic exams. Some 75% of women present with advanced malignant disease as evidenced by abdominal pain and bloating, a palpable abdominal mass, and ascites. Benign and versus malignant pelvic masses, finding benign and malignant. Okay, now examination, pelvic mass. Okay, so finding, so mobility in benign is going to be mobile, consistency is going to be cystic, cul-de-sac is smooth, transvaginal sonography, and adnexal mass. Okay, so for size, it's going to be less than 8 centimeters, cystic, consistency, separation, septations are going to be unilocular, location is going to be unilateral, and others, calcification. For malignant, the mobility is fixed. Consistency is solid or firm. Cul-de-sac is nodular. Size of the adnexal mass is going to be more than 8 centimeters. Consistency is going to be solid or cystic and solid. Okay. Septation is going to be multilocular. Location is bilateral, and others is cysts. Okay, so table this differentiates the benign and malignant characteristics of pelvic masses. Did that. Diagnosis, tumor markers. See this table. Increase in CA125. Okay, so that's the is associated with epithelial cell cancer, 90% of ovarian cancers, but is used only as a marker for progression and recurrence. Premenopausal women with increased CA125 may point to benign disease such as endometriosis or a tubal ovarian abscess. Okay, so endometriosis is tubal if it's premenopausal. Okay, and if it's post-menopausal women, then increase in CA125 more than 35 units indicates a increased likelihood that the ovarian tumor is malignant. Transvaginal ultrasonography used to screen high-risk patients and as the first step in the workup of symptomatic females, for example, pelvic fullness, pelvic pain. A solid mass with thick septations with or without ascites on ultrasound is highly suggestive of neoplasm. Okay. Key fact here is granulosa cells tumor predisposes to endometrial hyperplasia and carcinoma because of unopposed estrogen secretion. From step one, my mnemonic for granulosa was grandma cell tumor, right? Grandma because of estrogen. It's something I just remember now. It makes absolutely no sense. But I basically attached estrogen to granulosa at that point, and I just remember that way. So estrogen with grandma cell tumor. Okay. Key fact: any ovarian or adnexal mass in a premenarchal or postmenopausal patient is suggestive of an ovarian neoplasm. Okay, so any ovarian or adnexal mass in a premenarchal or postmenopausal patient is suggestive of ovarian neoplasm. Treatment: ovarian mass is in premenarchal females. Mass of more than 2 cm in diameter require close clinical follow-up and often surgical removal. Ovarian masses in premenopausal females. Observation is appropriate for the asymptomatic, mobile, unilateral, simple cystic masses less than 8 to 10 centimeters in diameter. Most resolve spontaneously. Surgical evaluation of masses more than 8 to 10 centimeters in diameter, and those that are complex and or unchanged on repetitive pelvic examinations and ultrasonography. Ovarian masses in postmenopausal females closely follow with ultrasonography, asymptomatic, unilateral simple cyst, less than 5 centimeters in diameter with a normal CA125. Surgically evaluate palpable masses. Okay. Ovary. Okay. Surgical evaluation of the masses more than 8 to 10 centimeters. Okay. Otherwise, we just do ultrasonography. Okay. Ovarian tumor characteristics. Tumor marker and characteristic. Epithelial tumor is giving you CA125. Serous adenocarcinoma, the most common. A tumor may present with abdominal distension, bowel obstruction, and adnexal mass. Okay. Wasn't that okay? Yeah. Endodermal sinus, yolk sac, alpha fetoprotein AFP is the marker for that. So if there's AFP, then endodermal sinus is what you're going to be thinking of, yolk sac. Characteristic very aggressive, and endodermal sinus may be seen in ovaries and or sacrococcygeal area in young children. Gross examination shows a yellow friable solid mass. Okay. You have AFB, but you also have beta HCG, then that's embryonal carcinoma. Very rare, embryonal carcinoma may be seen in adolescents. It may present with precocious puberty and abnormal uterine bleeding. Choriocarcinoma, of course, the marker is beta HCG, can develop during or after pregnancy and after molar pregnancies. This is malignancy of trophoblastic tissue. Choriocarcinoma may be associated with bilateral theca lutein cells. It spreads hematogenously. Dysgerminoma, here the marker is LDH, lactate dehydrogenase, most commonly seen in adolescents with sheets of uniform fried egg cells. And then you have granulosa cells or inhibin, most common malignant stromal tumor. Granulosa cells are often seen in females in their 50s. Production of estrogen, right? So granulosa cell tumors. That's where I got like grandma thing from, because it's females in 50s and they produce estrogen. So production of estrogen and or progesterone may lead to postmenopausal bleeding. Call Exener bodies on histology. Okay, then we have ovarian cancer treatment, surgery, surgical staging, hysterectomy or BSO with omentectomy and pelvic and para-aortic lymphadenectomy. Benign neoplasms warrant tumor removal or unilateral oophorectomy. Perioperative chemotherapy, routine except for female with early stage or low grade ovarian cancer. Radiation therapy, reserved for advanced germ cell tumors, in particular dysgerminoma, not effective in epithelial ovarian cancer. Prevention, females with BRCA1 gene mutation should be screened every 6 months with ultrasonography and CA125 testing. Prophylactic oophorectomy is recommended by 40 years of age or whenever childbearing is completed. OCP use reduce the risk for ovarian cancer. There is no routine screening for ovarian cancer. Okay. Urologic gynecology. Okay. Pelvic organ prolapse. Risk factor for pelvic organ prolapse include multiple vaginal deliveries, genetic predisposition or advancing age, prior pelvic surgery, hysterectomy, connective tissue disorder, and increased intra-abdominal pressure associated with obesity or straining with chronic constipation. History and physical examination presents with the sensation of a bulge or protrusion in the vagina, see this figure, urinary or fecal incontinence, a sense of incomplete bladder emptying and or dysper there's that word again, dyspareunia are also seen. Diagnosis: the degree of prolapse can be evaluated by having the patient perform the Valsalva maneuver while in the lithotomy position. Treatment: supportive measures include a high fiber diet, weight reduction in obese patients, and limitations on straining and lifting. PCREs may reduce prolapse and are helpful in patients who do not wish to undergo surgery or in those for whom surgery is contraindicated. Surgical procedures depend on where the prolapse is located. Uterine prolapse is treated by a hysterectomy with vaginal wall suspension. Anterior posterior wall, vaginal wall. A prolapse here calls for repair of the anterior or posterior wall. Call for happy what? Okay, a prolapse here calls for repair of the anterior or posterior wall. Okay, and uterine prolapse is treated with hysterectomy with vaginal wall suspension. Okay, so high fiber diet, so they're not straining, weight reduction in obese patient, and limitation on straining and lifting. Okay. Normal. This is what it looks like. Doctors. Bare bone suffices. Bladder. The uterus. Okay. Cervix, vagina. Okay. And this is the anus. So you have uterine prolapse, then slight prolapse like that. Won't slip down. Marked prolapse, prosidentia. Okay. Slip down real hard. Okay. So that was uterine prolapse. Very informative. Thank you. Diagrams depicting different degrees of uterine prolapse. Okay. Sexual disorders. Genital pelvic pain disorder. It's vaginismus. Involuntary spasm of outer 1/3 of the vagina. History and physical examination. Some caused by situational psychosocial causes. Can be associated with gynecologic disorders, chronic medical conditions, or certain medications. Treatment. Most effective cognitive and behavioral psychotherapy with systemic desensitization, deep muscle relaxation techniques, and dilators. Vulvodynia, localized pain of the vulva, usually pain with insertion at introitious. History and physical examination, typically chronic and idiopathic. Treatment at start of the treatment, detailed history and physical examination, multidisciplinary treatment with pelvic floor, physical therapy, and counseling. Okay, so, and physical sexual interest arousal disorder, inability to complete sexual activity, history and physical examination, common in patients with depression and chronic disease, common in younger patients due to situational circumstances or depression. Treatment here is usually resolves when underlying conditions or medications is adjusted, individual or couple psychotherapy. Okay, and that's it. Oh my god. I think that was the most comprehensive chapter I read here. And I'm not going to be able to remember a lot of this stuff. It's going to require multiple reads, which I don't have the time to do. But if you guys are in the same boat, then I would recommend going through the step 1, at least the cancer portion of this chapter, the reproach chapter, for whichever one that you're having a hard time with. Because I'm going to do the same thing if I'm having a hard time in your world. But anyways, that's it. See you in the next one. What's the next one? Yep. See you.